Yes.
Yes, please start in 3, 2, 1. We are live.
Namaskar and good evening, everyone. I welcome you all on the second day of the webinar on recent advances in breast and lung cancer. And for this, with immense pleasure, I would like to welcome Dr. Srinivas KG, who is consultant medical oncologist, Bharat Hospital Institute, Mysore, and for the welcome and introductory note and to set the ball rolling and to take the proceeding further. Over to you, sir.
Thank you, Ektaji. Good evening, all. I welcome all the attendees, delegates, speakers, friends, teachers for this wonderful meeting. Yesterday, we had a day 1 session of breast cancer symposium. Today, day 2 being lung cancer symposium, and I welcome all the speakers. I welcome Dr. Shivani, who is an oncopathologist, consultant oncopathologist from Co-Diagnostics, Delhi, to the first presentation, Genomics in Lung Cancer. Over to you, ma'am.
Thank you, sir. Thank you for giving me this opportunity. I would like to share my screen now, if you allow me, please. Thank you. Is my screen visible?
No, ma'am.
Not it, Dr. Shivani.
Okay. I am seeing yours, like I'm sharing the screen, but
Are you able to share the screen? The green one, the center one?
yeah, I'm able to see that.
Ektaji, can you just support team? Can you just help her for sharing the screen? Anybody from support team?
Ma'am, you have to share your screen by pressing on share screen in the Zoom and then clicking on the PPT. Can you share it with us for the backup so that we can run from our end?
Yeah, sure. I'm just doing that.
Okay.
Just a minute. I think I'm not able to send it.
You can share your screen.
I'll try it again. Just a minute. Okay, I'll share it again.
Dr. Shivani, can you just mail the slides or something? Did you do that?
Can you send me the email ID quickly? I'll just email it.
1 second. I'm just sharing it to your mobile.
Yeah.
Yes.
Just a minute. Can you see my screen now?
Yeah, I think we are seeing your screen. Yeah.
Can you see my presentation?
Now we can see. Yes.
Okay, amazing. Sorry for the glitch. So you can see my first slide with the photograph of my lab, right?
Yes. Yes. Very much. It's very beautiful.
Great. So that's where we are. We are placed in Gurgaon. Hello, everybody. I'm Dr. Shivani, Lab Director, Core Diagnostics. Today, we are going to take a very beautiful journey on genomics of lung cancer, where we are as on today. So as we begin, I would always love to go to the basics. We know that genetic and epigenetic alterations lead to most of the lung cancers. And the two most broad pathways are activation of growth promoting pathway or inhibition of tumor suppressor pathway. So if we go back to our genetic classes, we know that there is either an activation mutation, which is causing an increased activity in the cell, or there is some kind of a fusion that is happening, which is causing a fusion protein. We can have an amplification where the number of the amplicons have increased because the gene has multiplied number of times, or there could be a deletion of a component. So what does NCCN tell us? So the recent update has told us and is guiding us towards a broad molecular profiling, which will include testing, which should be conducted as a part of it, and include a lot of mutations which are targetable. This includes EGFR, ALK, KRAS, ROS1, BRAF, NTRK, MET exon 14 skipping mutation, and RET. So this is what we are presently guided to do in advanced and metastatic disease of lung cancer, which is the most common presentation as on today. But what are we trying to look for? We're looking for the treatment that can be provided, either a chemotherapy or a targeted therapy or any checkpoint inhibitors. So a lung cancer patient undergoes a lot of tests, and there are a lot of options as on today for the patient to understand which kind of therapy can be taken. So this is our age-old EGFR mutation, the classical exon 18, 19, 20, and 21. What's new in the box? Few years back, we started talking about T790M, and as on today, we talk about osimertinib resistance. So this is a recent study which explains us that the type of EGFR mutation in a T790M positive non-small cell lung cancer patient prior to treatment can actually predict the resistance. The point that I want to bring here is that there are two main type of mutations that are seen in case of a patient who is treated on osimertinib. One is T790M loss, another is C797S. And I have an interesting story of a patient for all of you in the coming slides. The second mutation is the ALK rearrangements. We know that ALK, the most common gene partner is EML4, but there are other partners also. But as on today, we are talking about the resistance mechanisms. So resistance in any kind of mutation is discussed as primary or secondary. And to simplify it to a very simpler way, it is either ALK dependent or ALK independent. So ALK dependent, we know that G1202R is the most common ALK-dependent mutation that we see in the patients who are being treated with lorlatinib. But we also know that there are bypass mechanisms that come up with HER2, EGFR, MET, KIT, and IGF. This is the reason that in more of the liquid biopsies, we see more kind of concomitant mutations together. There are other things that are occurring parallel in cancer, which is EMT, which is the epithelial mesenchymal transition, or a small cell lung cancer transformation. This highlights that a rebiopsy at times is really helpful to understand this. So I went back to see what ASCO was teaching us, and I found this interesting poster there, which says that the driver coexistence characteristics of ALK fusion in Chinese patients with lung cancer was seen. And it was very interesting to see that 2.89% of patients had concomitant mutations with ALK. And the partners most common were EGFR, L858R. There was KRAS, MET amplification was seen with ALK. We had HER2 and fusion of ROS1 and RET. Now, this brings a new set of patients in front of us who are now coming up with coexistent mutations. Coming on to the KRAS mutations, the KRAS mutations are 25% of non-small cell lung cancer, more so a prognostic marker, but we know that mutated KRAS causes increased signaling despite the upstream EGFR inhibition. What's new here is that we know that the most common KRAS genotype still is PG12C, which is seen most commonly, but what we are trying to now find out is other factors which can relate to this. And this is an interesting presentation in ASCO this time, which showed that the solid predominant adenocarcinoma phenotype may be an independent predictive factor for poor clinical course. Going on to the Rosman fusions, ROS1 is a gene rearrangement which we see very commonly, started off with doing FISH. We have IHC, which can be done, and I would like to highlight an interesting study that we did on correlation of ROS1 IHC with FISH to understand the enigma that why ALK IHCs can be done, but not ROS1. So ROS1 IHC is still facing problems in the specificity of the test, which is around 63%. However, it is very sensitive, about 94%. This was published in South Asian Journal of Cancer. This is the new person in the box, which is NTRK gene fusions. Interestingly, only 0.2%, but yes, we have the targetable gene, so why not? And there are 3 types, 1, 2, and 3. 2 very important things I would like to highlight here. One, that the IHC is available, but actually, right, as on today, is facing problems because of the background overexpression that already exists in certain tumor. So the best modality would be NGS. It is very important to understand that the NGS is done with RNA also. If RNA is not done, it will be difficult to detect 1 and 3 types in NTRK. Going on to the BRAF, we know that V600E is the most common type. We are now moving forward to various classes of BRAF, where either the BRAF is present as a dimer or is RAS dependent. So we are now slowly moving to further typifying these mutations because we are increasingly finding them out. In our data, we have only a few percentage of these cases, but it will be interesting to have more number of cases in coming years and having a different subclassification for these tumors. MET exon 14 skipping, I'll take a little time to have an understanding on this. There are 2 very important mutations that you see in MET. One is MET exon 14 skipping. So this diagram shows that the entire exon 14 gets skipped, and it is actually a whole exon deletion. So 2 important sites here are the splicer acceptor site and splicer donor site. So these are the 2 very important areas here. There is a second type of mutation that occurs in MET, which is MET amplification, which is a CLV. So these are 2 main types of mutations which we should understand which are there. What I interestingly found that this is one of the presentations in the ASCO this time, where we are looking at a whole transcriptome sequencing, which means that we have now understood that which kind of donor splice site mutation is most common, and it is seen that it is the point mutation which is the most common, and it is the splice site mutation which is the second most common. Also, that beside the splicing alteration, a MET co-amplification is also being seen in these. So these are subgroup of patients who are usually very old, non-smokers. So it will be interesting to understand how these patients do, and as and when we get more data around it. Going on to the next most important mutation, which is RET fusions with multiple partners. FISH has been the most important modality till now, but we have had cases NGS has picked up. So I think it is good to go for NGS too. Last but not the least, we have PD-L1 immune checkpoint for 22C3, SP142, and SP263. It is very important. We have got huge data now. We know how these patients, how these immunostains work. We have got enough people and labs now reporting this, and we also have a good data. So one of them presented by our team, it's a PD-L1 expression and its clinico-pathological and genomic correlation in non-small cell lung cancer. We tried to find out the correlation of PD-L1 expression with EGFR concomitant mutation and which kind of mutation it was positive. And it was interesting that like we did, there was somebody in ASCO this time who presented that PD-L1 score can be a prognostic biomarker in Asian patients with early stage EGFR mutated lung cancer. Interestingly, if it is a higher PD-L1 score, then significantly it is associated with a worse disease-free survival or overall survival. So before I end PD-L1, we have a new test in the corner, which is desmocolin-3 expression. It is a study which has been published only on 12 patients, but I would like to talk about it because we are about to launch it in our lab too. So this is a marker which is most commonly seen in the squamous type of the lung cancer. Català has a drug for it. So this is going to be in the next talk of the town. So briefly, with all the discussion that I had, we are very clear that we have NGS as a modality which can cover all these broad genomic profiling of NCCN. But yes, we have the FISH, we have IHC, and we also have PCR, which is still there and exists. And it is the call of the oncologist which one they would like to prefer. But I would like to highlight that NGS would help us to have novel mutations, which help us to collate and understand this data about resistant mutations, concomitant mutations in lung cancer. It helps us to have a rapid, high throughput and accurate data. We are able to match our data with the people worldwide, and that is really good. It becomes cost effective only when the volumes are more, and I think we are moving towards it. The best part is that paraffin block and a liquid biopsy can be done together. So this is our Pulmocore 12 gene panel that we do. We recently introduced it, which has all the genes that I discussed right now with the depth of coverage of 500. And briefly, a very small data that I have of the 12 gene panel is here. And you can see that we have, gotten up a lot of mutations that I have been talking about. So it is interesting to see how these patients eventually work. And as and when the more data comes in, it will be very interesting to see this data in coming few months. I would next like to briefly go to liquid biopsy because any lung genomics is incomplete without it. So blood is a gold mine of information, whether it is CTC, microRNA, circulatory RNA, CTEC, exosomes, or ctDNA. I said ctDNA the last, but I think that's the most important part of the diagnosis in liquid biopsy as of today. It is interesting that we know this from 1948, but our landmark happened in 2006. So briefly, I would describe the pre-analytic factors. There is a very short half-life of the ctDNA in blood, which makes it very vulnerable to a lot of factors. So we need to have a correct type of tube in which the sample is taken. The sample has to be transported in a particular temperature to have the correct results. Definitely narrow-based RT-PCR and ddPCR we have been doing for a long time, but we have now reached the NGS where SNV, indels, CNVs, and gene rearrangements can be done. Post-analytic, believe me, it's not very easy to analyze these samples. There are background mutations called the CHIP mutations, which occur in the somatic cells, which we need of the WBCs, which we need to see. And we have to now detect a very low frequency mutation against a very large wild type. But the softwares, the bioinformatics team, all these work together really well, and we are able to get good data. So we have two panels in-house, which is LiquiCode 12 gene panel and LiquiCode 52 gene panel that we do, of which this is one of the data where the publication is underway with 246 cases for a time period of 2 years. The percentage positivity has been 63%. We found EGFR to be 46% and ALK to be 9%. But what made us really interesting this data is that we have got concomitant mutations in 19%. And the most common is EGFR and ALK. So this is an interesting patient. Just to highlight how liquid biopsy can change the life of the patient, we had a patient who came to us with adenocarcinoma lung, which had an ALK and EGFR negative from outside report. We did a liquid biopsy on the patient and found EGFR T790M and exon 19 deletion positive in 2020. In 1 year after osimertinib, we again progressed. We again did a liquid biopsy and we found EGFR C797S resistant mutation for osimertinib in this patient and completely changed the course. So twice the liquid biopsy changed the course of the treatment of this patient. So we're also trying to do a concordance data of the block and the liquid together and trying to find out most of this is a very small data, but we are finding mutations very accurate. But yes, we are catching more EGFR in liquid biopsy. Coming on to a little hype that is all around liquid biopsy, we have CTCs on the rack where we have single cell that can be detected, which is shed from the primary tumor. And a small inset here shows how a bright red color is seen around the CTC. But yes, this test lacks standardization of isolation. It has very short life, very low detection rate, and the long-term preservation is not possible. But a lot of work is being done on this. Maybe in coming time, this is going to be a very important test for us. MicroRNAs, although very stable molecule in terms of getting us information, but do not show specificity for any type of cancer, have very high variability according to the patients and the technologies. Tumor-derived exosomes are the latest. I will talk about PD-L1 in the exosomes in the coming slides. So the extraction, approach, detection, and characterization methods are still a challenge and require standardization with high costs. So we have transfer of tumor-related molecules to the platelets, and these are now called the tumor-educated platelets. We have a study from 2018 who identified 20 genes that are 78% sensitive for detecting adenocarcinoma in situ. So, but needs a very extensive study on this with large number of patients so that we can vouch on this kind of test as on today. Going on to the CTECs, so we correlate with the immunotherapeutic resistance. They can be quantified, but technically very challenging. There is no validated assay as of now, but yes, a lot of work is being done because neovascularization is a very important feature of any tumor. So if they turn out to be, they'll turn out to be a very good source of information for us. So this is the PD-L1 in liquid biopsy. In 2022, recently, a comparative study was done with radiomics, that is the radio diagnosis and liquid biopsy together. So these are extracellular vesicles which store PD-L1. So you've given PD-L1 to a patient, you want to know whether the patient has responded or not. We can go and check the levels of the PD-L1. If they are decreased inside this vesicle, the patient is responding. So therefore, this is called as delta EV. Very nice paper published in ASCO this time. So this is on the rocks that we will be able to, do PD-L1 testing on this. So blood tumor mutation burden, a little controversial topic, but why not? It is struggling still with weak predictive biomarker as a first-line treatment. I think the most important problem that it has is the cutoff, and I think still it is a surrogate of immune checkpoint and not the real message that we actually need. But yes, blood TMB is being done extensively now on liquid biopsies, and but there is a requirement for establishing the cutoff for the immune response. Lastly, I would say minimal residual disease. We have been doing it for a long time. There is quantitative PCR, ddPCR, beaming that already we do for lung cancer. But yes, there are artificial intelligence now being entering to get certain softwares for us, which includes CapSeq, TAMSeq, and SafeSeq. So we can do NGS and blood TMB, of course, for the minimal residual disease. So I would conclude my study by saying that once a patient reaches you, there are 3-4 things that we all consider. One, what is the relevance of this test, or a particular test for this patient? It should be right on the right topography and the timeline of the patient's disease. We need the report in time. What kind of urgency do we have? Is the test affordable for the patient is a very important aspect. We need to give the report in a very good quality measure so that we don't harm the patient. And the post-analysis of all the reports that we sign out is important to have a data together as to understand how the patients do with a certain test and the treatment. So before I end, I would like to thank all the patients because of whom you and me are sitting here and talking. I think they are a great source of information for us, and they make our living. Thank you so much.
Thank you, Dr. Shivani. That was an excellent presentation. You have done such a good homework. I can understand that when I asked you to do it, you fully justified the job. I can't thank enough for this wonderful presentation. Thank you so much.
Thank you.
So I welcome Dr. Linu Jacob, Professor and Head of the Department, Kidwai Memorial Institute of Oncology, to chair the next session. Dr. Linu, sir?
Yeah, I'm here.
So,
Good evening.
Good evening, sir. We'll move on to the next session, neoadjuvant therapies in lung cancer. First, I would like to welcome Dr. Rajiv, who is an associate professor in Kidwai Memorial Institute of Oncology. Dr. Rajiv.
Yes, I am there.
Over to you.
Can you see my slides?
Yes, sir.
Good evening, all. At the outset, I thank KG Srinivas.
Dr. Rajiv, sir, just make it full screen.
It's not done.
So you have to share your screen again.
It's not coming.
No, sir.
Dr. Rajiv, initially it came actually.
So you share your screen again and then go to it. Yes, sir, we can see your screen.
Dr. Rajiv, what happened?
Just a minute.
Okay.
So you are muted. You need to unmute yourself.
You can see my slides?
Yes, sir, we
Yes,
can
sir.
see your screen.
No?
Yeah.
It's moving?
No, it's not moving.
It's not moving.
No, sir, it's not moving.
Now?
Yeah, correct.
Yes, sir.
It's there, sir. Perfect.
Yeah. Sorry for the technical glitches. At the outset, I thank Srinivas for giving me the opportunity. I will be going through two phase 2 studies in operable lung cancer, that is resectable lung cancer. The first one is, you can make out here, this is a China study from the Hangzhou. It is 2-cycle versus 3-cycle neoadjuvant therapy. They used sintilimab plus platinum doublet with a resectable non-small cell lung cancer. They called it as a NEON-SCORE study. It is a single center, phase 2 trial. Coming to the background is neoadjuvant immune checkpoint inhibitor plus chemotherapy has shown promising efficacy in resectable non-small cell lung cancer. 2 to 4 cycle of neoadjuvant chemotherapy was generally used in most of the clinical cases. Currently, the consensus for the optimal periods remained unestablished. Sintilimab is a monoclonal antibody against PD-1, has exhibited favorable major pathological response rate in single-agent neoadjuvant setting. They wanted to see phase 2 study compared the efficacy and safety in 2-cycle versus 3-cycle in a resectable, that is 1B and 3A non-small cell lung cancers. So before going to the actual trial, whatever the evidence available is, we can see there are 4 phase 2 studies and 1 phase 3 study. That is a checkpoint checkmate 816. They have used it in the neoadjuvant. The molecule used is platinum doublet of the common with atezolizumab, nivolumab, toripalimab, and they used durvalumab also. In phase 3 checkmate, they looked in the nivolumab. You can see the major pathological response is around 57 and 57% with atezolizumab, with the major pathological complete response of 33%. And ADIM2, I will be presenting this also here 83 versus 63%. And if you come into the toripalimab, it is 67% major pathological response is 50% complete pathological response. And if you come to the platinum doublet with Durva, here also they does with 3 cycle, 2 cycle, it is 62% major pathological response versus 18% complete pathological response. If you see the checkmate trial, it is almost 36.9% major pathological with 24% complete pathological response. Coming to the actual trial, this is a phase 2 trial, single institute trial. They used histologically confirmed stage 1B, stage 3, that is resectable non-small cell. So they are all treatment naive, at least one measurable lesion. The number is 60. They randomized into 2 arms, 1:1 randomization with sertolizumab 200 milligram day 1 with chemotherapy for 2 cycles, and same with the 3 cycles. After that, they operated, surgery done with a 4 week after the last dose of the chemotherapy. Then they have given adjuvant treatment of 1 to 2 cycles with the maintenance of sentinelizumab. So what they looked in, and the stratification was done was TPS score in PDL1 dose, TPS score below 1% and above 1%. So the primary endpoint, what they looked was major pathological response rate. And secondary, of course, the many were there, pathological complete response, overall response rate, 2-year DFS and 2-year OFS with safety. Coming to the sample size, the planned sample size 1 or 2, 50 on each arm, but due to an unplanned interim analysis, data safety monitor board is recommended to terminate the trial. So by that time, they did only 60 patients. So flow diagram, so you can see the flow diagram, they screened 64, failed screening was 4, and randomized 60 into 1:1 arm, almost 29 and 31. So R0 resection was done in 26 patients in 2 cycles, and 29 patients in 3 cycles. So final analysis was done with efficacy and safety. The baseline characteristic, most of them are well matched. You can see the p-value, which was not significant. So coming to the primary endpoint, what they look major pathological response, the 3 cycle treatment represented 14.5% increase in the major pathological response rate, that is 26.19 with 41.4%. The p-value was not significant, maybe because of the narrow cycle difference and the small sample size. Coming to the secondary endpoint, the pathological complete response rate was 4.9% increase in the 3 cycle. Again, it was not pathologically, the p-value was not significant. That is 19.2 versus 24.1%. So you can see the waterfall spot. So here, these are all squamous cell. So squamous cell did better compared to the below LOS. Radiological response, you can see overall response rate was numerically better with 3 cycles compared to 2 cycles, but no significant p-value. The subgroup analysis, here also none of the parameters were clinically significant except for the clinical stage 3A. Here it is towards the benefit, that is 0.06. So most of the parameters were favoring 3 cycles, but they are not clinically significant. The p-value was not significant. The tumor response by the histology, you can see the squamous cell non-small cell achieved significantly higher major pathological rate. So you can see here they are significant by p-value also, even the odd ratio also. Here squamous and non-squamous, you can see 51.6% response in squamous compared to non-squamous 12.5%. In pathological complete response, even though you see numerical high rates in the squamous, but again the p-value was not significant. But the overall response rate again 61.3 in squamous and 41.7 in the non-squamous. Again, p-value was not significant. Only what the significant data we see here is major pathological response with squamous cell, non-small cell. Coming to the PDL1 TPS, there is a better tumor response was seen with the TPS more than 45%. You can see the cartoon here, right side. There is a, even if you see pathological regression and change in the tumor from the baseline, both were better with the TPS score more than 45%. Surgical details. So the planned surgery was conducted in almost 90% in 2 cycles and 93.5 with 3 cycles. So 3 cycles did not increase surgical risk of post-operative complication. You can see here 2 cycles or 3 cycles. There are no increased post-operative complications. Treatment-related adverse event, the safety parameters. Again, there were not much clinically significant thing was seen with 2 cycles versus 3 cycles. To conclude this study, so this is a first randomized study comparing different treatment periods of immunotherapy in the neoadjuvant setting. 3-cycle neoadjuvant treatment achieved numerically higher MPR, that is major pathological rate, compared to 2 cycles and was consistent across the most subgroup. That is 26.9% plus 41.4%. The major pathological rate was impressively higher in patient with squamous compared to the non-squamous. That we can make out. It is 60% in 3 cycles, 43.8% in 2 cycles. PDL expression had a modest predictive value for pathological response, and neoadjuvant regimen as an extra cycle has been tolerated. So our data suggests, the author concludes, more cycle of neoadjuvant immunotherapy provide higher major pathological rate for the patient with resectable non-small cell lung cancer, especially with squamous cell. So I'll go to the next study, that is NODIM-2. Here, nivolumab chemotherapy. This is from the European Spain. It is a multi-center study from the Spain. Here they used nivolumab with chemotherapy. So they also used stage 3 A and B, resectable stage 3 A and B. So here they in the last study you see MPR. Here they looked into the pathological complete response. Coming to the introduction, this is not applies to the India because our data will not be matching this, but maybe in the Spain they have this introduction. They have 80 to 85% lung cancer, approximately 20% present with stage 3, that is N2 disease. Multimodality treatment is necessary in this group. Outcome remains poor, almost 36% OS with 5 years. And preoperative CT has shown to significantly improve the overall survival in resectable non-small. That is hazard ratio for survival is 0.87. However, the absolute 5-year survival is only 5%. Strong association between the pathological complete response and survival was seen. That is hazard ratio of 0.49, that is 51% benefit. So the median rate of PCR after neoadjuvant is low, that is only 4%, ranging from 0 to 16%. So the neoadjuvant chemotherapy for resectable non-small shown promising activity in several single-arm phase 2 studies. The phase 3 CM816 major showed a higher rate of pathological complete response and tumor resection and improved event-free survival compared to the they have seen with neoadjuvant chemotherapy. This study randomized phase 2 evaluating the nivolumab adding into the chemotherapy. That is in the stage 3 A and B. So here we present primary endpoint as pathological complete response. This is the study design. Locally advanced potentially resectable non-small cell lung cancers. EGFR all were excluded in this study. It was a 2:1 randomization with 2 in the experimental arm. They used nivolumab plus paclitaxel, and in the control arm paclitaxel. After that, after 3 cycles they done the surgery. So surgery was done almost within a one month of the thing. So when they are R0 resection, they are given adjuvant treatment. They followed up for 5 years. So multiple things they looked into for the translational research. So the primary endpoint, they did pathological complete response with the intention to treat population, and secondary multiple parameters include MPR, and they want to see the adverse event and safety tolerability and potential predictive markers also. Statistical plan, this is a population was defined for those patients, that is a intent to treat or principle, and pathological complete response defined as any absence of any viable tumor. And referring on to the results of phase 2 NADIM trial, we assumed PCR of 10% in the control arm, 40% in the experimental arm. The study power 5% alpha with 80% delta, and dropout rate 15%. They wanted to include 90 patients, 60 in the experimental arm, 30 in the control arm. So this is the flow diagram. So 90 was randomized and 4 were excluded. In the experimental arm, there was 57, and the control arm that was 29. They resected 53 in the experimental arm and 20 in the control arm. So the baseline parameters almost well matched. There was no difference with that. They are well matched. Coming to the baseline characteristic, this is a list. You can't expect this to be matched. So surgical summary from this. So what they have done, patient with definitive surgery, the odds ratio is 5.96. It is 69 versus 93%. So you can see the P was significant in the benefiting the experimental arm. The primary endpoint with pathological complete response. So you can see the here odds ratio 7.88. That is 6.9 to 36. So almost 29% benefit was seen with this with the experimental arm. The percentage of patients with complete pathological response. Coming to the major pathological response secondary endpoint. Again, the odds ratio was 6.94. You can see the significant p-value with 14 versus 53, almost 40%. 40% difference was also seen. And what you have to see is the NNT, that is number needed to treat, even with pathological, which is 3.34, and major pathological response is 2.57. And coming to the overall response rate, again, odds ratio was 3.29 with significant p-value, that is 48% with 75%. So adverse event, the grade 3 and grade 4, as expected, experimental arm had a higher, almost 15% higher response, but there were no deaths in both the arms. Coming to the secondary endpoint, safety parameters, most of them was well manageable, but in the experimental arm, you can see the fatigue and febrile neutropenia was seen more. Coming to the predictive biomarker of response, what they have seen, the PCR had higher with the PDL expression in patient who did not. That is, who achieved higher PCR, they had higher PDL expression. PCR rate raised across increasing category, that is TPS more. Predictive value of TPS, PDL1 TPS for CPR was area under curve, that is 0.78, that is significant p-value. Odds ratio for PCR in the PDL1 group, that is more than 1%, is 60. You can see the cartoon, higher the PDL1, better will be the response. So conclude this study, NADIM2 confirmed superiority of neoadjuvant nivolumab plus chemotherapy combination in patient with resectable stage 3 A and B non-small cell lung cancer. And the addition of neoadjuvant nivolumab to the chemotherapy significantly improved the PCR and maintained a tolerable safety profile and did not impede feasibility of the surgery. And PD-L1 TPS is a predictive value for pathological complete response. Thank you. Thank you for the patience hearing. I'm happy to take any questions here.
Thank you, sir. Next, we'll move on to Dr. Rudresh presentation. Then we'll take Dr. Linu sir's expert comments. Dr. Rudresh, over to you.
At the outset, I thank Srinivas for giving me this opportunity. So I will be speaking two abstracts. Can you see my slides?
Rudresh, make it full screen, no?
Yeah, it is full screen only.
You are not able to see the full screen actually. Just put it in the slideshow mode.
Now?
Just not really. Support team. Just
Actually,
help
in my
me.
this thing, it is full screen only.
Egfr ji.
Rudresh,
No.
you exit and reshare. Rudresh, you exit and reshare. Stop share.
Yeah, stop share, sir, and then reshare. Yes, sir. Move to slideshow mode.
Now you can see.
Yeah, we can see.
Okay.
Can you just scroll down? Yeah. Yes, sir. Yes, sir.
Slideshow.
No, it's not in the slideshow mode. You need to make it.
Click on the slideshow mode, Rudresh.
Yeah,
Click on the slideshow.
In my screen, it is in the slideshow only.
Is that okay? We can go ahead.
Yeah, we can proceed. So we are able to
Please
see.
go ahead, Dr. Rudresh.
Yeah, thank you. Thank you, Srinivas, for giving me this opportunity. I will be speaking on two abstracts. One is consolidation nivolumab plus nivolumab or nivolumab alone after chemoradiation for unresectable stage 3 NSCLC. This trial was designed when Pacific data was first being presented. In this trial and in the Pacific trial, they showed a significant improvement in PFS with use of single agent immunotherapy for 12 months. But most of the patients did not receive for 12 months. Only 40% in each trial were able to continue and complete the treatment. And additional analysis of our trial showed no detriment when patients got less than 12 months. So this trial designed to look for a shorter interval of that is 6 months with combination nivolumab plus ipilimumab. So in this, so this is the study design. So where concurrent chemoradiation was given along with the platinum doublet chemotherapy. So patient who progressed were not eligible for this study, and patient who achieved either stable disease or any response, let it be partial or complete response, after the inclusion of eligibility criteria, they randomized into 1:1 ratio, and the subject stratified on stage 3A and 3B, and depending on the histology, whether it is squamous cell or non-squamous cell. In the arm 1, they given nivolumab 480 milligram IV every 4th weekly for 4 cycles. That is once in a month for 6 months. And in arm 2, they given nivolumab 240 mg every 2 weekly plus ipilimumab 1 mg per kg every 6 weeks. So total they given 4 cycles like this. So total duration of treatment in both arms were 6 months. And this is a open label multi-site randomized phase 2 trial, and it is an investigator initiated trial, and it is funded by BMS. And all patients received concurrent chemoradiation prior to the enrollment. And the patients were given in arm A nivolumab, that is 480 milligram IV once in a month, and in arm 2, along with the nivolumab, which was given once in 2 weeks, 240 mg IV. In ipilimumab, they given 1 mg per kg once in 6 weeks, total 4 cycles. So coming to the adverse event, here you can see patients who are on nivolumab plus ipilimumab the treatment-related adverse events were more. Overall, 80% versus 70% in nivolumab, and also grade 3 or more adverse events were more with nivolumab plus ipilimumab. That is 50%. Here it is 35%. And also almost all the side effects were a bit more in the combination arm compared to the nivolumab alone. And coming to the pneumonitis were more commonly seen with combination immunotherapy compared to the nivolumab alone. And also grade 4 or 5 pneumonitis were seen in 9 patients within the combination, whereas in 5 patients in the nivolumab alone. So the toxicity were more. With the combination nivolumab plus ipilimumab, and the particular interest there was higher rates of pneumonitis.
Rudresh, sorry to interrupt. Your slides are not moving.
No.
Yes, sir. Now it's moving.
No.
Yes, sir. Now it is moving.
Okay. So the patients who are on combination nivolumab plus ipilimumab are more toxicity compared to nivolumab alone. And the primary endpoint was 18 months of PFS, and secondary endpoint of this study was PFS, overall survival, time to metastatic disease or death, and exploratory to correlate with PD-L1 and other ctDNA as a predictive or prognostic factors. In this nivolumab alone, the 18 months PFS was 63.7 months, whereas in combination it is 67.6 months, and p-value in both the arms were less than 0.1. And median months is 25.8 months with nivolumab alone, and in the combination it is 25.4 months. And overall survival 18 months, it is almost the same. There is no difference in 24 months. That is on 2 years. It is 80 months in combination and 77.7 months in nivolumab arm. So this is the progression PFS and OS. So with 6 months of treatment with nivolumab or nivolumab plus ipilimumab, actually there is no difference in the PFS and also in the OS. So take home points: 18 months, the PFS and 2-year OS compares favorably to the specific trial, despite only 6 months of therapy, and there is no major difference in the baseline characteristic between the trials. And PD-L1 analysis will be interesting to see. What are the other extra information it will be giving. So nivolumab plus ipilimumab combination is more challenging to give with more overall toxicity and pneumonitis. And though most of the patients recovered well, and there was no grade 4 or 5 pneumonitis. And these arms were not meant to be compared, but currently no major improvement in PFS OS for use of combination IO. And also the possibility that nivolumab alone overperform, which makes combination is no better. That means to say the nivolumab alone for 6 months as an adjuvant therapy is sufficient compared to the combination, rather than giving for 6 months, 1 year. So coming to the second trial, that is neoadjuvant nivolumab plus platinum doublet. You can see my slides, correct?
Yes, sir.
Yeah. So neoadjuvant nivolumab plus platinum doublet chemotherapy versus chemotherapy for resectable, that is stage 1B to stage 3A NSCLC, and the association of pathological regression with event-free survival in the Checkmate 816 trial. So as we know, in breast cancer, PCR plays a major important role in both overall survival, but in the lung it is not very much documented, though it is documented in chemotherapy, but not in the immunotherapy. So the several studies have shown there is an association between the pathological response and survival with neoadjuvant chemotherapy in resectable NSCLC, but so the same not shown in the immunotherapy. In this randomized phase 3 Checkmate 816 study, neoadjuvant nivolumab plus chemotherapy has significantly improved the primary endpoints of EFS and pathological CR versus chemo in patients with resectable NSCLC, with median EFS was 31.6 months versus 20.8 months, with hazard ratio 0.6, and PCR rates were 24% versus 2.2%. Additionally, neoadjuvant nivolumab plus chemo also improved the major pathological response and showed improvement in the interim overall survival compared to chemotherapy alone. So this combination is now indicated in most of the United States as an neoadjuvant treatment for adult patients with resectable, that is more than 4 centimeter or node positive NSCLC. So in this study, we will presenting the post-hoc analysis evaluating the association between the pathological regression and event-free survival. So in this Checkmate 816 study, the adults with resectable NSCLC with no known EGFR alteration, so there should not be any driver mutations, and ECOG performance status is 0 and were enrolled, and the primary endpoint was EFS and PCR. The EFS is the standard deviation. The PCR is the 0% residual viable tumor cells in both primary lung and in the sampled lymph nodes. And the major pathological response definition is less than 10% of residual viable tissue cells in both primary or in the sampled lymph nodes. And in this post-hoc analysis was conducted to evaluate the association of PCR and EFS in patient who underwent surgery and had pathologically evaluable sample. And EFS was evaluated by PCR or that is major pathological response in the primary tumor, and the depth of pathological regression, that is measured by the percentage of residual viable tumor in the primary tumor, and a time-dependent receiver operating characteristic, that RO-seeker was used to assess the predictive ability of the percentage of residual viable tumor for event-free survival at the outcome at 2 years. So this is the study design. The eligibility criteria: any patient newly diagnosed with resectable, that is stage 1B, that is more than 4 centimeter, up to stage 3A NSCLC with ECOG performance status 0-1, no known EGFR or ARC mutation, and patient were stratified depending on the stage, that is stage 1B2 versus stage 3, and depending on the PD-L1 expression, that is less than 1% or more than 1%. And in the 1:1 randomization, in the one arm, along with chemo, nivolumab 360 mg once in 3 weeks, and the chemotherapy once in 3 cycles. After the radiological restaging, the total 3 cycles of chemo or chemo plus nivolumab was given. Radiological staging was done, and surgery within 6 weeks of post-treatment was done, and optional adjuvant chemo plus RT was planned. The primary endpoint was PCR and EFS, and secondary endpoint was major pathological response, OS, or time to death, or distant METs. And the key exploratory analysis was EFS by pathological regression. The baseline characteristic of the patient, both in the path evaluable or concurrently randomized or well matched, including sex, the region, performance status, stage, and histology, and also depending on the smoking status, the expression of the PD-L1 and TMB also well matched in both concurrently randomized. Afterwards, post surgery in path evaluable patients also it is well matched. So coming to the EFS in both the nivolumab plus chemo and chemo arms in path evaluable patient population, EFS was improved in patient with versus those without PCR in the primary tumor. So patient who achieved PCR, the EFS was better both in chemo plus immunotherapy and also in the chemotherapy alone arm. And this is consistent with the results in the concurrently randomized population where PCR was assessed in both primary and the lymph nodes. And the similar trend of improved EFS was observed regardless of the baseline stage of the disease and the tumor PD-L1 expression in nivo plus chemo arm. The subgroup analysis was not able to done in the chemo arm because of the low sample size. So this is the PFS, that is event-free survival with the combination at 1 year and at 24 months, 12 months and 24 months. At 12 months, it is 93% versus 79%. Patient who can able to achieve PCR, and it is 93% who achieves the PCR with the combination nivolumab plus chemo versus the patient who unable to achieve the PCR. So the median PFS patient were not reached in patient who achieved the PCR, and it is 27.8 months who patient unable to achieve the PCR, and the hazard ratio is 0.18. So coming to the stage wise, in stage 1B and 2, And also, if the baseline stage 3, the PCR is translated into the event-free survival at 1 year. At least 1 year, that is 70% versus 90%, and at 2 years, it is 56% versus 90% in stage 1B and 2. And in stage 3 also, it has achieved the better EFS in patient who can able to achieve the PCR. That is, at 1 year, it is 83% versus 96%. At 2 years, it is 60 versus 96%. And beyond 2 years also, the patient who achieved PCR has fared well compared to patient who does not achieve the PCR. And coming to the PD-L1 expression, less than 1 or more than 1%, actually there is no much difference, but though patient who is having more than PD-L1 expression more than 1% has done well beyond 2 years of treatment. So patient who achieved the major pathological response, if patient not achieved PCR, but they can able to achieve the major pathological response, in them also there is a event-free survival, which is not yet reached in the nivolumab plus chemo versus patient who unable to achieve the major pathological response. So in the ROC curve also, so in the path available patient population, percentage of residual viable tissue as a continuous variable, which appeared to be a predictive of event-free survival at 2 years for nivolumab plus chemotherapy, which is based on the AUC value of 0.74. This AUC value of 0.74 was not achieved in chemotherapy alone arm. So hence, so the ROC curve analysis was not holds good in chemo alone. The optimal cutoff was 5% of residual viable tissue, suggesting that threshold values 5% to maximize the diagnosticability of the percentage of RVT for EFS at 2 years for combination R. So this is the R. So with combination with immunotherapy and the chemotherapy, has shown this ROC benefit, but not in the chemotherapy alone arm. And another important factor is the depth of pathological regression, which was assessed by percentage of residual viable tissue. In this, the path available patient population, patient treated with nivolumab plus chemo achieved the deeper pathological regression as previously reported. Based on this ROC curve, event-free survival outcomes were further assessed in patient treated with nivolumab plus chemo and add 0 to 5% or more than 5 to 30%, more than 30 to 80%, and more than 80% RVT in the primary tumor. And you can see here the 2 year event-free survival rates for 90% if patient is having only 0 to 5% residual viable tissue, and it is 40% in patient who is having more than 80% of the residual viable tissue. So in this, you can see the 45% of the patient who achieved the residual viable tissue of more than 5% have achieved better event-free survival compared to the patient in whom there was more than 80% of the RVT. And the event-free survival, depending on the percentage of residual viable tissue, depending on the category, here you can see patient who achieved the very good response, that is only 0 to 5% of residual viable tissue done better compared to the patient who achieved more than 80% of, who is having more than 80% of residual viable tissue. And the median event-free survival patient with 0 to 5% of residual viable tumor, it is not yet reached, whereas more than 80%, it is almost 18 months. And coming to the safety in path available patient population, the incidence of treatment-related adverse events in nivolumab plus chemo arm was similar in patient with or without PCR or major pathological response, which is consistent with the all treated patients. So safety is almost the same in treated and who achieve the pathological CR. There is no difference. in the this one. To coming to the conclusion in this postdoc analysis, that this checkmate 816 provides the first in-depth assessment of the pathological regression and event-free survival in phase 3 trial with neoadjuvant immunotherapy. And this event-free survival was improved with neoadjuvant nivolumab plus chemo and chemo in patient who achieves the PCR or major pathological response in the primary tumor relative to those without. And the patient with deeper pathological regression in the primary tumor with neoadjuvant immunotherapy plus chemotherapy appear to have better event-free survival outcomes at 2 years. And this neoadjuvant nivolumab plus chemo showed a similar safety profile in patients with or without PCR or major pathological response and was overall consistent with the previous reports. So these results of this checkmate 816 along with previously reported data continue to support the pathological response as an early indicator of event-free survival benefit with neoadjuvant nivolumab plus chemotherapy. Thank you.
Dr. Linu sir, over to you.
Yeah, so once again, congratulations, Dr. Srinivas, for conducting this very enlightening meeting, bringing in all the important abstracts of the ASCO 2022. I think I know that I think we are a little behind the schedule by at least 30 minutes. So what we heard in the last 15 to 20 minutes was 4 abstracts in the NSCLC setting, 3 abstracts in the neoadjuvant setting, and 1 abstract in the consolidation, that is post chemo radiation setting. And we all know that nivolumab plus platinum-based doublet chemotherapy has already been established as the standard of care based on the checkmate 816 trial. And now that the neoadjuvant immunotherapy plus chemo is already established, we can naturally expect more trials to happen in this setting, probably looking at the ideal number of cycles before surgery, just as we did in the breast cancer setting. So the Nadim-2 trial, the other 2 trials, those are all looking at the various the combinations of the different immuno-oncology agents along with the platinum doublet chemotherapy. So anyway, we know that that is the standard of care as of now, and the higher the PCR rates, higher the event-free survival. So that is also been shown in the Postdoc analysis of the checkmate 816 trial. As far as the 1 abstract in the consolidation setting post-CTRT is concerned, this particular study where 6 months of nivolumab or a combination of nivolumab plus ipilimumab was used in the consolidation setting post-CTRT. This brings in the question whether we really need to give 12 months of consolidation, even though probably we don't have studies with the durvalumab in that particular setting, but I feel that that is something which we can definitely consider in our practice. Again, drawing parallels to breast, maybe at 12 months of trastuzumab versus 6 months of trastuzumab. So I think those are my comments. Thank you. Thank you to Dr. Srinivas as well as to Dr. Rajiv and Dr. Rudresh for very clearly presenting those abstracts.
Thank you, sir. I thank Dr. Rajiv and Dr. Rudresh for that wonderful presentation. And I thank Dr. Linu, sir, for the valuable inputs. Just with much ado, I'll move on to the next session because we are already running behind. Next session would be on optimizing radiation therapy in lung cancer to Balakrishnan Nair, sir. Dr. Balakrishnan Nair, sir, is a consultant radiation oncologist in CMC Vellore. Very good friend of mine. Over to you, sir.
Can you see my screen?
Yes, sir.
Yeah, thank you. Thank you, Srinivas, for that introduction. I'm very happy to be part of this meeting. And once again, thanks for that invitation. So I've been given 15 minutes to tell you about optimizing radiotherapy in lung cancer with respect to what has been presented in the ASCO 2022. So just a brief introduction about me. I work as currently a professor in radiation oncology in CMC Vellore. I've been in radiation oncology since 2004. I focus on head and neck, lung, GI, and prostate, and I do SBRT also. And my research focus is currently on AI in radiation oncology and developing electronic PROM modules in cancer. So before I go into the abstracts that I have selected to present before you, I just summarize what is the role of radiation in lung cancer. Obviously, you would know that when it comes to non-small cell lung cancer, if it is resectable, obviously surgery is the cornerstone. But in patients who are inoperable and poor lung function, we can offer SBRT, ablative treatment for cure. Even with poor lung function, we can do that because it's a small field of radiation. Then in the post-operative setting, that is in a resected patient, when there is a high-risk feature for recurrence, that is either an upstaged N2 with certain caveat in it. I mean, and in R1 and R2 resection, we do offer post-operative radiotherapy. And then in advanced unresectable non-metastatic lung cancer, that is basically our stage 3Bs, which are referred to us for sequential or concurrent chemoradiotherapy, which is the cornerstone of radiotherapy in non-small cell lung cancer. And then now upcoming indications in metastatic cancer, whether it is mutation driven or non-mutation driven, we are getting more and more referrals for radiating when there is an oligo progression, or when there is a good partial or complete response. Questions are asked whether we can ablate the residual disease. Then obviously palliation, whole brain RT, SR is always a debate that has become more and more prominent with the different biology of lung cancer that we are seeing. Whether mutation-driven cancers need radiation upfront or not is a question. Then there is bone metastasis, which are palliated, and obviously for pain control. When it comes to small cell lung cancer, there is limited stage where we offer chemoradiation as a curative approach, and of course prophylactic cranial radiation. And in extensive stage disease, we get referrals for consolidating the primary when there is a good response post chemotherapy. And in some patients, we do offer prophylactic cranial radiation. So that's the brief about the role of a radiation oncologist in treatment of lung cancer. It is quite varied. And what I did is I went through the ASCO lung abstracts, and then I found out 25 lung cancer abstracts mentioning radiotherapy and 9 mentioning radiation. I just focus on abstracts which has a direct focus on radiotherapy as an intervention, and those who have a good message for clinical practice. So 5 abstracts I've selected, which I would be presenting here. So first one is neoadjuvant chemo radiotherapy or neoadjuvant chemotherapy for stage 3 with mediastinal lymph node non-small cell lung cancer. So low burden mediastinal disease, of course, in the West, people do offer surgery. Here, it depends on the surgeon. If it is staged properly, yes, and they are resectable, yes, I would prefer a surgery. And this is actually a review of cases done between 2004 and 2015, whether they're getting neoadjuvant chemoradiotherapy versus just chemotherapy alone. And what they have reported is that the cancer-specific survival is better in chemoradiotherapy arm, but overall survival remains the same. So what do we interpret from this study is that neoadjuvant chemo, currently what we follow is that neoadjuvant chemo is the standard in a resectable setting, except for maybe I would say Pancoast tumor, where we do neoadjuvant chemoradiotherapy. But of course, neoadjuvant chemo, or now currently addition of immunotherapy, is also the standard. So chemo RT is seldom offered. This is a 2004 to 15 data. So obviously there is a shift in management approach. The drugs have completely changed. So I don't know whether this data holds good. And I feel from this study also, it says resectable non-small cell lung cancer, whether mediastinal node is positive or not, it should go for surgery. And but there is this lung art trial which was published in Lancet recently, which have actually defined the role of port, which clearly says that if it is a resectable lung cancer, then there is no role for post-operative radiotherapy. So that brings us to actually another abstract, which was also interesting, in which a group of surgeons actually reviewed the lung art cohort, and they actually looked at the surgical quality and impact of the quality of resection on the survival. So they just surmised in a good table, and I'm just presenting this table. If you can look at it, the mediastinal nodes examined were median numbers were around 11 and 8, depending on the side of the tumor. And if you look at it, these were all low burden mediastinal node positive, low burden N2 disease. That is a median of 2 nodes or 1 node were positive. And R1 resections were 30% and R2 resections were only 2 out of the 501. So these are all basically well-selected resectable non-small cell lung cancer with a mediastinal lymph node present before surgery. So what happens to their survival? Their 3-year disease-free survival, if you look at in an R0 setting, the RT did not make a difference. That's what the lung art reported as overall. But if you look at an R1, there is a trend towards a better 3-year disease-free survival when RT is added. R unspecified is when they didn't have data about the R status. So there wasn't much difference. So if I interpret this, in R2 resection, we don't have any data to not offer postoperative radiotherapy. In a low volume N2 disease, I would say if it is resectable, we should proceed. And once completely dissected, there is no role for postoperative radiotherapy. In R0 resection, there is no postoperative radiotherapy. In R1, you can actually look at this data. This actually is impressive. Slight overlap of the confidence interval. Hence, this is not significant. So in my practice, I would really ask the surgeon as to, he would have seen what is inside and he would have resected. So I would ask whether he would feel safe to offer radiation or not. Then moving on, this is another important clinical question that comes to us at the end of a TKI treatment for a metastatic lung cancer, which is EGFR mutation driven, whether there is a role for radiation for that residual disease. So this is interestingly tested in a small group of patients. What they have presented is the median progression-free survival in a EGFR positive non-small cell lung cancer is 8 to 18 months. So what if we add SBRT to that residual disease group? So they had 2 groups of patients which had SBRT plus TKI and only TKI alone. So this is after either achieving a stable disease or a partial response with initial treatment of TKI. And the primary endpoint was progression-free survival, and that obviously overall survival was looked at. So there was definite benefit in treating the with radiotherapy, whatever is residual, and there was a survival advantage also seen. They also looked at the acquired T790M mutation, and they found out that both groups were similar in terms of mutation. So that didn't actually make a difference in terms of this result. Fourth one, this is also interesting. Now we know that immunotherapy is added as adjuvant to patients with radical chemoradiation, that is stage 3B patients. Durvalumab Pacific trial data has come in, but we also use other checkpoint inhibitors. So what happens to patients? We know that in India, many may not get it because of the cost. So this I found relevance because they have actually looked at the patterns of failure with and without addition of immunotherapy, whether that makes a difference. What is the difference it makes? So chemoradiotherapy with concurrent or sequential immunotherapy, 39 patients were taken who had immunotherapy with chemoradiation, and they selected another set of 39 patients, matched cohort, and they looked at the first site of failure as a primary endpoint. They followed up these patients for a median of 3 years. So what happened is that obviously there is a improvement in median overall survival and PFS with addition of immunotherapy. So the question was, what was this first site of failure? So the brain mets, extracranial mets, multi-organ progression, everything was similar. But interesting fact is that the loco-regional recurrence was much lesser in the chemoradiation plus immunotherapy arm, and median time to loco-regional recurrence was also longer. So thus immunotherapy did have a benefit in improving the local control also, which is different from what we thought actually. And this is again similar. This is a group which actually looked at the historical use of immunotherapy along with chemoradiation. They looked at 2011 to 2014, 15 to 17, and 18 to 2020. I felt that there is a change in management approach between these cohorts, so it's important to actually look at this data. across all cohorts, addition of immunotherapy actually improved survival, median PFS and overall survival. Obviously, the last cohort we haven't, it's very recent because 2020, so we haven't reached the median point. Okay, I did tell you that whether to radiate patients with brain mets when there is a mutation-driven cancer is always a question. And this is a this is basically a systematic review on small cell lung cancer, because non-small cell lung cancer, we know that SRS and whole brain RT is standard when there is metastasis, depending on the number of metastases. But in small cell lung cancer, we feel that it is a very highly metastatic disease. So we offer mostly whole brain RT only. This group looked at whether to offer SRS plus whole brain RT. And obviously, it's a small cohort. Obviously, they feel the picture is similar to what we see in non-small cell lung cancer. But I would still wait for more data. I would still feel that whole brain RT is a cornerstone for small cell lung cancer brain metastasis treatment. Okay, some points from other abstracts that I have read regarding radiation. As I told you, the question of whether to radiate a patient with brain metastasis when it is a mutation-driven cancer, and we feel that it can get good intracranial control. For that, this lung molecular GPA index was a tool which has actually created an index which actually clearly defines which patients to give early radiation and which patients you can actually delay the radiation. So you may look into this as a future marker or a predictor for selecting patients for early radiotherapy in terms of brain metastasis. The CALGB trial, which actually defines small cell lung cancer better survival with twice daily radiotherapy. Interestingly, the quality of life was evaluated on the same group and found out that there is very poor quality of life during the time of radiation and after that if we do twice daily radiotherapy, which actually justifies our own practice also, because in India we also seldom do twice daily radiation because it's very difficult and inconvenient for the patient. There is always a query when radiation pneumonitis sets in, and now that you use immunotherapy along with it, whether this is due to pneumonitis from radiotherapy or pneumonitis induced by durvalumab or any other immunotherapeutic agent. So now we have this radiomics one paper. They have done the texture-based analysis. There are many other radiomic features that could be used. Texture-based is probably TexRad they had used, and they have found a way to actually distinguish
apologies, sir, you are left with 1 minute.
This is the last slide. Yeah, radiation. TexRad could actually distinguish between these two causes of pneumonitis. And next two are basically radiotherapy. Chemo RT with immunotherapy, they have actually introduced more dose volume parameters to assess the plan before before finalizing the plan for radiotherapy. So that's mostly about it. And I think I gave you an overview of the radiotherapy abstracts in ASCO. I would be happy to answer any questions if you have any. Thanks.
Thank you, Balu sir. That was an excellent presentation. I want to welcome Dr. Vishwesharaya sir, who is our senior most radiation oncologist. Actually, he was supposed to, he's chairing the session. I forgot to mention it. I'm extremely sorry. Dr. Vishwesharaya sir, your expert opinion.
First, Dr. Balakrishnan, I congratulate you that initially you gave the overview either in early lung cancer or in the non-resectable and later on moved on to the metastatic setup. Definitely, these basic principles remain same, and the Langard study, everything, as you said, 2 decades back or a decade and a half back, the techniques of radiation and the improvements in the technology have made us to rethink of use of radiation effectively that you have excellently delivered in your lecture. And with the addition of nowadays with the immunotherapy, I think definitely the responses are getting better and better. And we understand our limitations of each drug we use for the patient, maybe it a radiation or maybe this immunological agent. So the ultimate goal is to improve the survival. And as we said, as you said, very clearly in small cell carcinoma, the quality of life also remains an important issue. So once again, I thank you very much. And I feel all the audience have been enlightened with the overall lecture, overall points he made. And the take-home messages are very simple and they were very clear. And this is what I would say from my side. Thank you. Thank you.
So for a minute, can you stop sharing your screen? For a just a
I welcome Dr. Krishna Prasad sir for the next session on real-world data on osimertinib in EGFR mutant metastatic non-small cell lung cancer. This is AstraZeneca sponsored session. Welcome you, sir. Good evening, sir.
Thank you, Srinivas. Can I share the slides?
Sir is actually in Singapore. He took all the pain to present this. I can't thank enough him. Thank you, sir. Thanks for the accepting the invitation and
Thanks for the invitation. Yeah, so my job is basically to look at osimertinib as the standard of care in the management of first-line EGFR mutant non-small cell lung cancer. So we all knew for a long time that in patients with EGFR mutations, the progression-free survival significantly improves with TKIs compared with cytotoxic chemotherapy in a patient with mutation in EGFR. Now, FLORA was a landmark study. It was presented by Suresh Ramalingam in 2019. So what was this trial about? So basically patients with the advanced non-small cell lung cancer who had either mutation in a DEL19 mutation or an L858R were taken up for either osimertinib compared to gefitinib or erlotinib. Now, these patients were stratified by the mutation type as well as the race. Now, this is a classical baseline characteristics, what we call the 2/3. If you look at it carefully, the median age was around 64 years. 2/3 were females, Asians, never smokers with a performance status of 1 and who had exon 19 deletion. So 2/3 were all these characteristics. Now, what did it show? It showed a significant benefit in terms of progression-free survival. It improved from a median progression-free interval of 10.2 months to 18.9 months with a hazard ratio of 0.46. If you look on the right, you can see that virtually all subgroups benefited from osimertinib compared to the first generation TKI. When it came to the overall survival, also, you can see that osimertinib had a significant benefit with an improvement in median overall survival from 31.8 months to 38.6 months with a hazard ratio of 0.799. Now, what it did is it became undisputed that osimertinib was the preferred category 1 recommendation for all patients who had mutation in EGFR, that is 19 deletion or L858R, compared to any other drug. Now, whether this is the whole pizza or are we missing a small portion of it? Now, even though FLORA, unequivocally established osimertinib as the best treatment option, it is estimated that only around 2% of our patients actually receive treatment within a randomized clinical trial setting. So whether these small percentage of patients actually represent our entire population. In this scenario, the real world data have become very useful in assessing the role of any new drug which has been used in the community. So I will look at briefly at 6 studies in detail only in the first 2 and just a mention of the others. So the first study which I would like to go through is called the FLOWER study, basically presented by Martina Lorenzi in 2021 and then later on published in The Oncologist. So it looked at a first-line osimertinib in these patients. It was a prospective observational study. Anybody above the age of 18 to 20 with a histological diagnosis of stage 4 non-small cell lung cancer with a mutation in exon 18 to 21. Of course, they excluded patients who got the drug in the clinical trial. The important thing was the study endpoint. It was not the usual median overall survival of progression-free survival. They were, of course, the secondary endpoints, but the primary endpoint is the median time to treatment discontinuation. Now, this is becoming a pragmatic real-world endpoint to assess the effectiveness of any anti-cancer treatment. This is because we tend to continue treatment beyond progression as per the registered criteria in virtually most of our patients. So maybe this is the best way to go forward. If you look at the baseline characteristic, it was not a very big study. Flora had more than 500 patients. This had only 126 patients. Three things to notice clearly. The percentage of patients with brain metastasis was significantly higher, 17 to 19% in Flora, and here it is around 30%. Also, they included rare mutation. Remember, Flora included only exon 19 deletion and L858R, whereas this small percentage, of course, 5% had rare mutation and complex mutation. Also, this real-world data included patients with a performance status of 2 or more. Remember, Flora never included anybody with a PS more than 1. So what did it show? It showed a clinical benefit percentage of around 96%. Only there were no CRs, and around 73% was PR. So this study included patients with poor performance status, with multiple comorbidities, rare mutations, active brain metastasis, and at a median follow-up of 12.3 months, bang on, the median progression-free survival was exactly the same as Flora, that is 18.9 months. Median overall survival has not yet been reached, and this data actually contributes to value to Flora data because it shows consistency in osimertinib efficacy. Of course, patients who did not have brain metastasis did better. Also, patients who presented without any significant symptoms did much better than patients who had multiple symptoms due to the disease. There was no difference in PFS or treatment discontinuation duration or overall survival in elderly patients, and also patients with some of these rarer mutations, suggesting that osimertinib is effective in these patients. Also, the time to treatment discontinuation was much longer than the post-progression outcomes in Flora. Again, probably because some of our patients are unfit to change treatment, and also we would like to probably radiate the patient and continue the same drug for when there is oligoprogression. So basic idea in this study was that poor treatment outcome for patients with brain metastasis and patients who had symptoms at presentation and more than 3 metastatic sites suggests that probably the tumor load is a negative prognostic factor. Also, once the patients experience progressive disease, what is the percentage who undergo a rebiopsy? It's only 47.7%. And out of that, 2/3 underwent a tissue biopsy and 1/3 underwent a liquid biopsy. And in these biopsies, remember, molecular analysis was performed in only 2/3 of these samples. And out of them, we could find that MET amplification was the commonest resistant mechanism. What about safety data? Common side effects which we are all aware of: diarrhea, rash, dry skin, paronychia was common. Venous thromboembolism was higher in this group compared to Flora data. This came in at around 7.9 to 9%, depending on the grade which you are looking at. In Flora data, if you look carefully, the incidence of venous thromboembolism is higher in the 3rd generation osimertinib compared to 1st generation. So in summarizing, when you compare it with Flora, it's a much smaller study. Median progression-free survival is the same. More patients with brain metastasis, poor general condition, comorbidities were included, and thromboembolism was more common. So the take home from this is that osimertinib has good effectiveness in the real world population. Thromboembolism is slightly more common, and there are groups of patients who have a worse prognosis. If you look at the second study, this is from Japan, called the OCFACT study, which investigated the differences in efficacy in this Japanese group of patients in terms of real world scenario. Now, they included patients with advanced EGFR positive non-small cell lung cancer who have been started on osimertinib. Now, basically, this is a retrospective study with the primary endpoint being a progression-free survival. So if you look at the baseline characteristics, It included patients even with PS2, 3, and there were 4 patients with PS4 also. This is what we do in our clinical practice, isn't it? Also, 5.5% of patients had uncommon mutations. And interestingly, they did PDL1 study in these group of patients, and they found that around 30% of them had a PDL1 percentage between 1 to 49%, and around 12% had a PDL1 percentage more than 50%. Again, quite significant number of them had brain metastasis. In this group of patients, which is quite large, you look at it nearly the same number as FLORA, the median progression-free survival was slightly better at 20.5 months. And interestingly, patients with L858R in Japan did relatively better than in the FLORA study. So when they did a multivariate analysis, they found these 5 factors to be associated with poor progression-free survival. Being a male, having malignant effusions, liver metastasis, having L858R compared to having DEL19, and having uncommon mutation. And very interestingly, any kind of PDL1 expression was associated with a poorer progression-free survival. Regarding pneumonitis, it is well known in the FLORA. If you look at the Japanese subgroup, the incidence of pneumonitis is slightly higher. Whether that is also responsible or whether in real world data, 12.8% had pneumonitis, and around 4.5% had grade 3 and more. So it is quite significant pneumonitis. If you look at the discontinuation, 219 out of 500 and odd patients discontinued. Of course, the commonest reason was disease progression, but 25% of these patients who had discontinuation was because of pneumonitis. So in this study from Japan, what you can conclude is that the progression-free survival with first-line osimertinib is quite favorable, but pneumonitis requires further investigation. So the third trial is the Mykonos trial. This was basically a global observational prospective study going on in US, Europe, and Asia. This is not completed and is supposed to be completed only next year. This is a sub-analysis mainly containing patients from US. In this, the assessment or the endpoint was basically the real world time to next treatment or death, or time to discontinuation of treatment. So interestingly, if you look at it, majority of the patients are not from academic centers. 83.8% is from the community oncology center, which majority of us also belong to. PS2 and more, again, formed 14.5%, and quite significant number of them had brain metastasis at beginning. Again, if you look at the mutation type, 50% had exon 19 deletion, 33 had L858R, and quite a significant number had a mixture as some uncommon mutation. What they found out is around 58% of patients in this interim analysis remained on first-line osimertinib therapy, and around 103 patients changed on to second line, which was a combination of PDL1 or a single agent PDL1 therapy in majority of them. 101 patients died while on the treatment. So when they looked at the real world time to next treatment or death, it was around 17.9 months. And if you look at the time to treatment discontinuation, it was 17.2 months. So what happened to these patients? Around 100 patients died, 100 patients switched to second line, and 4.7% of them discontinued but did not take any other treatment. So in this particular group of patients, what they found out, the persons with multiple comorbidities with a Charlson index more than 3, having a poorer performance status, and having L858R or uncommon mutations, having multiple metastatic sites, especially liver metastasis, did poorer compared to patients not having this, bad points. So this study actually provides a good insight into how exactly first-line osimertinib is used in the US population in advanced EGFR mutant non-small cell lung cancer. And this supports osimertinib as a very good treatment option in the real world setting. So lastly, coming on to 2-3 other small publications. This was published last year in by Chung-Shin Lee, basically from the US, where they had a small group of 172 patients. 30% of them received osimertinib, and 70% nearly received the other TKIs. If you look at it, progression-free survival at the first 6 months, there was no difference. But as you went on, at 12 and 18 months, there was significant benefit of using osimertinib compared to the other TKI. So this was basically a comparison between the first generation and the third generation. Then another study from Japan called the HOT 2002, where basically they looked at the elderly patients. Now, this is important because many of our lung cancer patients are elderly, and you can see this group, the actual median age was 80 years. And even PS2, at the age of 80 years, they've taken up these patients for osimertinib. So if you look at it, L858R forms a big percentage. 56.8% of these patients had L858R. Does it suggest that as we age, the incidence of L858R actually increases? Something to be thought about. You can see that most of these patients had multiple comorbidities, and the Charlson comorbidity index was pretty high. 1 year progression-free survival was around 65.8%, and the median progression-free survival was around 20 months. Median overall survival has not yet reached. So quite significant benefit with osimertinib, even in this elderly group of patients. Two interesting things in this trial: 40% of them required dose reduction, but you can see that there is no difference in terms of benefit. So you can reduce the dose in elderly people without loss of benefit. Patients with poor performance status and patients who develop pneumonitis, they do very badly if they in terms of both progression-free survival as well as overall survival. So if the patient develops pneumonitis, then they do badly. If you have to dose reduce due to any other reason, generally they do reasonably well. So this showed that osimertinib is a very good treatment option even for the elderly, but we need to be careful of pneumonitis. So there is a study going on called the RIVA study, basically looking at real world observation of osimertinib as first line in these patients with EGFR mutant non-small cell lung cancer. This is still not completed. So what are the takeaway points, from these real world evidence? Is our pizza complete? Yeah, probably. The median progression-free survival seems to be in line with FLORA in all these real-world data. Patients with poor performance status, the elderly patients, patients with multiple comorbidities, rarer mutations, patients with active brain metastasis are all included in the real-world data and seem to develop some benefit from this. Two red flags: development of pneumonitis, especially in elderly, and in one of the studies, development of venous thromboembolism. I thank Srinivas and his team for this opportunity, and I would stop here. Thanks, sir.
Thank you so much, sir, for that excellent presentation. We always enjoy your talk. Very pleasure to listen to you always.
Thank you. Thank you, Srinivas.
Thank you, sir. Thank you very much again. So we'll move on to the next session. Dr. Vinayak Maka, a consultant and head Department of Medical Oncology, Ramaya Medical College, Bangalore. This session will be chaired by Dr. Vijay Agarwal. I welcome Dr. Vijay Agarwal, who is a senior consultant at Aster Hospital, Aster CMI, Bangalore. Dr. Vijay Agarwal, are you there?
Yes, Dr. Srinivas. Thank you. Thank you very much.
So I welcome Dr. Vinayak Maka now for presenting the 3 abstracts. Over to you.
Thank you, Srinivas, and thank you to give opportunity to me. And I think I really like the KP sir's presentation because with great difficulty we reach osimertinib. So I'm going to talk about beyond that. I have 3 slides. It will be one after one. So the first is optimization of treatment options. Can you hear me?
Yes,
hello?
very much.
So treatment options for EGFR mutated stage 3 unresectable cancers. This is a systemic review and meta-analysis where they look close. So we looked closely 2 subset of patients which have seen tremendously since last 2 decades. Stage 3 unresectable lung cancer, where we have seen evolution of concurrent CTRT followed by IO therapy since last
5 years with the specific data. I think recently we had a hot debate on this, what to do with EGFR mutated patients who are post CTRT. Till the LAURA comes, these are the analysis we can work on. And as we've seen earlier, we have data for EGFR TK from the first generation to the third generation and adjuvant, and the logical end is the third stage. So this is the consort diagrams. We have studied for 17 studies were studied and around 3,000 patients were taken. The treatment arm included concurrent CTRT, CTRT followed by immunotherapy, TK alone, radiotherapy followed by TK, CTRT followed by TK. The primary endpoints were PFS and OS, and other response rates were seen. So this is the Bayes analysis, what they've done. It's a busy slide, concentrate on the takeaway that overall response rate for RT and TK was significantly higher than CTRT alone. So there's definitely benefit of adding TK more than concurrent chemotherapy which we give. And this is only for response rates. PFS of the TK regimes are much better than CTRT alone. PFS of both RT and CTRT with TK are significantly better than CTRT with durvalumab. This is a question which we were discussing hotly, but I think this is relevant for our practice. TK alone has significant shorter life, so you can't do a TK alone. We need to have some local therapy. All these treatment arms has no difference in OS because it is not powered for that. But I think based on ranking, RT followed by TK has a better thing. But I think we have to wait for the LAURA study. The toxicity profile, if you see, all side effects which were seen were accumulated and seen. Radiation pneumonitis and esophagitis were very much increased in patients who received TK. Neutropenia was most common in patients who had received CTRT with TK. And I think durvalumab administration along with either using TK post or along with the IO therapy had been severe side effects. So the concluding radiation local therapy is essential and TK are essential. As of now, the data exists. RT with TK can be optimal regimes, but I think we have to look forward for LAURA data. CTRT followed by TK, till the LAURA data comes, we have to wait for it. But definitely one thing is that TK using post immunotherapy has severe side effects, and we have to be very aware of. So second topic which was given to me was beyond aura, novel approach in those subsets. As we know, there are a lot of issues with EGFR mutated lung cancer. I think Dr. KB sir has nicely described there is a pie missing. There are a lot of missing pieces in that pie. The quality of life, immunotherapy, how do we deal with Exon 20, early monitoring of using ctDNA or using in early disease TKIs. So two aspects which I will look after is one is overcoming the osimertinib resistance and improving the outcomes in Exon 20 insertions. In our practice, I have not seen much of Exon 20 insertions because they're not looked in. So recently I had 2-3 patients, but they didn't do well. So this is a felt need of our medical oncologist. So we going to the rationale why osimertinib resistance occur. It can be on-target resistance due to the tyrosine kinase domain mutations, which you see to 10 to 25% of the cases. Whereas there are the bypass mechanisms where the downstream pathways are activated in MET and HER2, which are responsible for almost 15% in MET and HER2 too. So if you're going to overcome the osimertinib resistance, this pathways has to be targeted. Apart from this, there's the histological transformation into the small cell lung cancer, which has to be addressed in a different format. So the drugs which we are using for addressing this osimertinib resistance is already almost the drug is ready. Monoclonal antibody amivantinib and new 4th generation TKIs. In the bypass resistance pathway, I think EGFR combinations, osimertinib and newer TKIs, that's the lazitinib, and selective MET inhibitors such as savolitinib. They're all tongue twisters, but I think spare me if I'm not pronouncing it correct. So we have 2 more ADCs. Deruxtecan is not just one which we heard, but there are a lot of ADCs which target various pathways. For example, if you target HER3 pathway, patritumab, deruxtecan, and if you are targeting TOP-T, datopotamab. Okay, we'll stick to that. So these are the novel therapies post third generation TKI, which has been the data is available. It is combination amivantamab with lacetinib and other combinations. One thing you can see in this graph is that most of the drug combinations are effective more than 30%, which is our oncological threshold is met. And response duration is more than 6 months. In this subset of patients who are post-osimertinib progression, we think without treatment they have less than 6 months. And all of them are crossing the threshold of 6 months. So I think they are effective. Even though PFS is not reflecting, I think we have more effective therapies. So two abstracts which you're going to look in the one is tilosurmab vedotin and osimertinib combination. Tilosurmab V vedotin is a ADC which is directed against MET, and as a monotherapy has been used in patients who are expressing MET in NLCLC. The response rates have been around 36%, but this subset has been used in EGFR mutated all comers, where the response rate is around 11%. What we are looking is IHC expression, and it is response rates shoots up to 39%. They are not equal to MET amplification or exon 14 skip mutation. They usually target the MET receptors and internalize and bring their action. So the study which has been done has a population of exon 19 deletion. There is a pre-treated with osimertinib MET or amplification. They have been exposed to platinum therapy, and they have been exposed to osimertinib for more than 12 months. 58% of them were exposed to osimertinib. So overall response rate for this drug combination was 58%, which was very reasonable considering it was post osimertinib progression. And the side effects were very unique. That is peripheral neuropathy, because it's being ADC tagged to the drug, and peripheral edema, blurred visions, and myelosuppressive doses were less, but definitely it is there. So patients who are having EGFR mutation, there is a definitely role for doing a biomarker, and it's clinically available, and being IHC, it is low cost. There are a lot of questions which still not addressed in this abstracts, which we need for further study or further time to tell whether we need to use the archived tissue or we should use the new biopsies. And even though there is a biopsy material be there will be always in a same slide, there may be some areas which may show heterogeneity, or there may be time-related heterogeneities, which are called as spatial and temporal heterogeneity. And what effect the prior treatments plays roles is still not addressed. Coming to the next abstract, where they looked osimertinib and nectinumab in EGFR mutant NLCLC. All these studies are phase 1 studies, and to the practice, it will not relevant as of today. But if we can get access to trials, or we get a direction of where things are going. So again, this is a combination of monoclonal antibody and TK, third generation TK. Very interesting concept that they have done in a phase study, that they have included 5 cohorts. So the cohorts, there are 3 cohorts it works, and in 2 cohorts it does not work. Cohort A, it is the patients who are don't have T790 mutation, and they progress on first and second line. And for them, this PR is around 16%. I'm not very happy with the PFS benefit of less than 4 months, but definitely it was powered for that, and it was some response was acceptable. Whereas other 2 arms which it failed, it was even though it was T790 mutant, but it had progress on osimertinib first line. So those patients didn't do well, and patients who are T790 mutant and progressed on osimertinib, this 2 subset of patients didn't do well. Whereas exon 20 insertion, who had been treated with platinum-based therapy and had no exposure to third generation TKIs, had done well. 16%. That is all these cohorts had 16%, and these were the pathways which are targeted: MET and HER2 resistance. So you can see the waterfall curve, which shows varied response to osimertinib, whether it was given in first line, whether there is a T970 mutation, and based on that, we can see a clear separation the curve. I'm not very happy with the PFS benefit, but definitely it is had a lot of grade 3 adverse effects. A rash is there, and other lot of side effects which you can go through it. But definitely, how much of our patients can afford and how much of patients will benefit with the 2-3 months of treatment is questionable. So other ways to overcome the osimertinib resistance is using MABs, that is nectinumab and osimertinib. So what you've seen is there is 3 approaches where they have targeted the selectively EGFR or MET resistance, and the response wherever they use that with post osimertinib, they have been more successful. Around 47% patients, 40% was over response, whereas patients who not had no biomarker, for example, nectinumab, the response rates are 16%. Better biomarker selection would be better. So where there is no biomarker and there was ADC, they could overcome the osimertinib resistance, and the overall response rates were more than 30%. So concluding the resistance, that telosovodotin with osimertinib shows early activity, and patients express different disease progression depending upon the prior osimertinib. We need to look closely the specific groups which can get benefit, and the underlying resistance has to be elucidated. There may be a role for a repeat biopsy or having a liquid biopsy to get the resistance pathway. Easily available is MET IHC. I have not done, but definitely it is a low cost one. And nectinumab and osimertinib combination shows activity, but we need to enhance it by biomarker selection. Coming to exon 20 insertion mutations, they're less than 1%, and they are prognostically worse than other 2 subset of patients, which is exon 19 and LAR 858 mutation. There is various approaches have been there. Some of them are MAPs, amivantinib, and some of them are TKIs, which targets the tyrosine kinase dominance, mobocertinib, all tongue twisters, but all of them have been tried. It's all phase 1 or phase 2 study, 1B. We want to look too closely 2 abstracts. One is osimertinib with nectinumab and single agent sunitinib patients who are EGFR exon 2 insertion mutation. So coming to the first study, there is osimertinib with nectinumab in exon mutation. So basically they understood that osimertinib alone is not enough, so added a map to it. But despite addition of map, the response rates were 16%, and the PFS benefit was 6.9. It fell within the confidence limit, but I think we need to see a better data. Whereas monotherapy sunozertinib, which has had a multiple dose escalation and dose expansion trials, where they looked not only exon 20 insertion, they also looked at the exon 99 T790 mutation, so that they can have multiple indications for the patients. Even patients who had a brain mets immunotherapy, the overall response rate was 40%, disease control was 84%, and response duration was more than 5.9 months, and it is just touching the 6 months thing which we expect in this subset of patients. One thing interesting was that patients who received immunotherapy, for them the PRs were high, and who has not received PD-L1, grade 3 toxicities were a little more, but I don't think any meaningful outcome can be taken on this data. So these are the options we are available for exon 20 insertion therapy where we are target. So looking closely, the map that is amivantinib has 40% response rates, and the response duration is 11 months, and PFS is 8 months. Other subset of other drug which has similar effect is obicetinib, which response rates is 28% response rates, but interestingly, response duration is more than 17.5 months. So that is very effective. whereas side effects are seen in the both. I think it's our dictum that every drug which has effect will have side effect. And the newer drugs, sunvaritinib and MAB and osimertinib combination, very significant. So one thing is interesting is the CLN-081. I don't know what drug it is, but definitely that has much response rates, and even the response duration is more than 21 months. This slide is just for understanding. There is a lot of drugs are coming in the horizon. So we have 2 drugs data that sunvaritinib has come efficacy comparable to other safety profile to other drugs. Combination of MABs and TKI would be a reasonable option as the data are showing, but still the chapter is not closed. I think if, in future we'll have more answer to this subsets. So third study I'm going to be talking about is when our Tata study, that is a combination of geftinib and cisplatinum based chemotherapy was looked, and there was always a question that how would this do with osimertinib? And I think this phase 2 study, that is OPAL study, would looks into this one. Very interesting arm it had. It given a physician choice of using cisplatinum or carboplatin, and they had 4 cycles of cisplatinum pemetrexed, followed by maintenance PEM with osimertinib or carboplatin combination. The patient characteristics were similarly matched, except for there was a mutation, one patient who had both the mutations, otherwise it was matched. This is also had a very good response rate. If you see the cisplatinum cohort, all patients responded. So overall response was almost 90%, whereas CR rates were seen in more in carboplatin arm, but most of patients did respond to these combinations. So this is phase 2 study where PFS and OFS has to be taken with that kind of data thing. And interesting curve to see that 2 years curve not reaching even 50%. Very interesting curve for a lung cancer thing. I think this is are telling things for better for us. So side effects, as I expected, we have more myelosuppression with the carboplatin arm and more of mucositis and other toxicity, GI toxicity with cisplatinum arm. Both are tolerable. If you continue, patients who could continue on treatment were only 60%. Around in arm A, the cisplatinum only 57% continued, and arm B, they only 63% were continued. And at least duration of osimertinib given was 18 months in arm A, cisplatinum arm, and in arm B, it was 19 months. 4 cycles were given medianly, and both were easily given, cisplatinum and carboplatin, and maintenance was given for almost a year. This was the question where we looked as is it possible? Very interesting concept. I think maybe our sponsor will not be keen on doing such a study, but definitely it shows that we are able to address all the resistant clone upfront, and we will able to have much of benefit. I think my slides are over. I think hopefully I saved some time for everyone.
Thank you, Vinayak, for that excellent presentation. Dr. Vijay, I want your expert comments on this abstracts.
Yeah, no, thank you, Dr. Vinayak. That was really good and excellent. I think what this essentially shows is that we have a huge choices in terms of lung cancer now, both in terms of how to begin treatment initially as well as on progression. I mean, clearly, when you look at the stage 3, the LAURA study will tell us what to do in our EGFR mutated non-operable lung cancer. Currently, the data does not exist, but whatever Dr. Vinayak showed, the meta-analysis, the network analysis clearly shows that TKI is the way to go as opposed to immunotherapy. Obviously, the big question in those situations arise is that do we do radiation plus TKI or do we do CTRT plus TKI? And the data does not exist for either of them. I think when Dr. Vinayak clearly made a good case of giving radiation plus TKI, but I think if the patient is younger and fitter, we would probably also consider adding in chemotherapy to those group of patients. The second one was the novel approaches beyond the aura. What do we do in terms of progression on osimertinib? I think we have to identify secondary mechanisms of action. A lot of the trials that Dr. Vinayak showed gives us a kind of a snapshot of what the future is due to come. But as of now, how things stand is that we should be, as a part of our daily practice, biopsying patients on progression, which we currently don't do. So I think we have to make it as a habit. If the patient has progressed on a TKI, we have to biopsy. It should become a reflex. We should send it for NGS. Whether we treat based on it or not, at least we need to be able to gather some data on that. And if we get some good biomarkers for which we have access to medications, we should certainly try that. The third part, the OPAL study, I think we're good. We're going to leave it as it is for now. I don't think any one of us is going to be changing practice tomorrow in a clinic, adding chemotherapy to Osimer today. But I think it's food for thought, and maybe a larger phase 3 study, if it does happen, can throw some light into that. So I think for now, we will probably continue doing osimertinib, and I'm sure Dr. Vinayak would agree with that. Thank you.
Yeah, I totally agree with you, Dr. Vijay. As on today, we need not do that, but these are all the inputs which provokes us in different thinking process. You know, the new things are always welcome, so that it's evolving.
Thank you.
Thank you, Dr. Vijay. We'll move upon to next session. It's a case-based discussion on management of EGFR positive non-small cell lung cancer. I welcome Dr. Amit Rautan, senior consultant medical oncologist at Manipal Hospital, Bangalore. I welcome you, sir.
Thank you, Doctor.
I also welcome the panelists, Dr. Rajiv, consultant medical oncologist at BGS Global Hospital, Dr. Rudresh, associate professor, Department of Medical Oncology, Kidwai Hospital, Dr. Kiran, JSS Hospital, Mysore, and Dr. Meghala, radiation oncologist at Narayana Hospital, Mysore, and Dr. Vijay Kumar, surgical oncologist at HCG, Mysore. Over to you, sir.
Thank you, Dr. Srinivas. Thank you for giving me this opportunity. So we'll have 20 minutes. We'll quickly go through some cases. Right. So this is a case-based discussion. So let's discuss quickly early stage lung cancer. Here's our patient, left lung mass, gets mediastinal lymphadenopathy in the PET scan, no other metastatic disease, and gets operated. This is the histopathology report. You have invasive adenocarcinoma. There are 2 lymph nodes positive. It is T2N1M0 disease. So let's start off. Early stage adeno-CAP T2N1. Dr. Rajiv, do you test for molecular biomarkers in early stage lung cancer? And if you do you test single genes? Do you test NGS panels in early stage lung?
I will. Sir, I think panelists are there or not, I'm not sure.
Okay, Dr. Rudresh?
Dr.
Are you there?
Yeah, sir. I will check in the early stage also the biomarkers. Usually I will check for EGFR, but patient affordable, we can do all the EGFR, ALK and PD-L1. But yes, EGFR. But thing is, the number of cases what we are seeing in early stages are very, very less post-op. That too.
Right. Definitely. We see very few patients. Right. So EGFR definitely, EGFR ALK sometimes, NGS is rare. Dr. Kiran, do you test, and what level of testing?
Yeah, good evening, sir. Good evening, everyone. I agree with Rudresh, sir. Usually we test for EGFR and ALK most commonly. Apart from that, nowadays we are also testing for PD-L1 levels in the early cancer also.
Okay. And do you do NGS by any chance in early stage lung cancer?
Yes, sir. If patient is affordable, we will do it. If not, no.
Okay. So there's always a thought. Yeah. No, I think it's a very interesting space. There is no the requirement is definitely EGFR should be tested. I'm sure all of us are testing EGFR, ALK, ROS, PD-L1 also. And many of us are doing NGS testing. The tissue is there, so there's no harm in getting the information. Now, what we're going to do about it is very different, but I'm sure all of us in clinics are testing more and more. Okay, so this patient gets tested and you get a report which says it's a EGFR L858R. So you have an exon 21 mutation, and so this is how we want to decide next. So Dr. Kiran, how do you take this forward in your patient with this mutation? How would you treat this patient PT2N1M0?
So we'll go with adjuvant chemotherapy with doublet regimen, platinum doublet regimen.
Okay, and so platinum doublet is the standard you'd follow. Just
Yes,
a quick thought: do you treat all your patients with platinum doublet, even if it is stage 1A, 1B, or do you leave the 1Bs? What is your thought?
If it is 1B and above, I think we'll treat, sir.
1B and above, you do treat everyone.
Yes,
Okay, right. Dr. Rudresh, your thoughts after your adjuvant chemo?
Yeah. Any patient with more than 4 centimeter tumor size or any lymph node, mediastinal lymph node, we will go with adjuvant chemotherapy. If patient is affordable, we can give adjuvant osimertinib also.
Right.
Shown
So
better PFS, and also the type of recurrences will be better. That means localized rather than the distant recurrence in osimertinib. And also if there is a it will crosses the blood-brain barrier, where in the trial it has shown lesser brain recurrence. So yes, if they are affordable, osimertinib.
right. So you mentioned this is very rare, and I agree. All of us hardly see early stage patients. But have you used this in any patient in the early stage setting as of now?
No.
Right. No, even we've hardly seen this group of patients, though we are looking for them very actively. But yes, the early stage space is less. But I think all of us are very, very impressed with the PFS data, and the hazards were very significant. If you look at the hazards of stage 2, 3A, 0.17 hazard, and if you even include stage 1, the hazards are really good. Clearly, we've never seen this kind of hazard. So just to emphasize the point, when we use adjuvant chemotherapy in lung, we are using it on the LACE meta-analysis. We have a OS benefit of 5% at 5 years. The hazards were 0.89. We have a PFS benefit also, and the PFS benefit was actually approved on a hazard of 0.86. So now this is a PFS benefit here, So there's no way we can kind of deny and say this will be beneficial. But there are always hesitations, and that's always there. Dr. Kiran, you are advising it to your patients, or are you still hesitating on this?
Only thing is, once again, the cost of osimertinib, sir. Most of our patients cannot afford for treatment. I had one patient where he presented with stage 1B. Then we went ahead with 4 cycles of chemo, and we offered for some TKs also, but he was not affordable. Then he is on follow-up right now. Post 1 year, he is doing good. He's doing fine.
Okay. So there's nothing you've offered him, right?
Yes, sir.
Are you tempted to offer him gefitinib?
Yes, sir, but yeah, osimertinib is fine. Gefitinib, I don't know, sir.
Right. Okay. Yeah. So we know the PFS data is pretty good with gefitinib and erlotinib. It's not that the PFS data is poor; it's pretty good, but the OS was negative. So that's the reason why all of us become reluctant again, because we say if there's no OS benefit, then why do it? But I think all of us are pretty impressed with this. So Adora practice changing. I think all of us sort of have accepted this, that we believe Adora is practice changing. I have Dr. Vijay Kumar. So
I don't think he has joined. So. Dr. Meghala is there. So Dr. Meghala is a radiation oncologist.
You can include others also. What is there in the discussion?
Sir. Dr. Vinayak, if he is there, please join.
Vinayak and Vijay Agarwal, you can include.
Dr. Vijay Agarwal.
So, Dr. Vijay.
Hello, sir.
Yeah. This is
Dr. Amit, this is Dr. Vinayak.
Hi.
I think the usage is limited by the we able to get this patients that indicated one. If you, I mean, last almost the data has come for more than a year. I don't get a subset of patients where I could actually use this drug, where they were resected and there is EGFR positivity. No, I mean that's my thing. But definitely, if it is there, that's a practice changing. And I think, in fact, all TKS will come in all of the indications where systemic therapy is indicated. I think it's a practice changing. There's no doubt about it.
Right, right. So definitely, I also accept.
And I want to ask one more question. In this Adura trial also, it is showing PFS benefit. Still, OS is not yet matured.
Absolutely. Right. Absolutely. So that's the whole thing, are you convinced about this PFS benefit? And do you think the curves will fall down as you stop it once the period of treatment is over?
Dr. Vinayak, Dr. Amit, that's what Vinayak. So the thing is that there are few things with Adura, it's not addressed it properly. I think I'm okay with DFS as an endpoint. What I'm not okay is the platinum not being there. They were offered, but this is the hazard ratio of 2 is, I mean, like that hazard ratio is never heard, Very few trials have that kind of hazard ratio. I think we should, this is a practice changing actually, but is the only one option we have the database, or is the question?
Right. No, I think what you mentioned, 0.2 hazard. I can't believe it will not lead to an OS benefit. It's something that you can never see in oncology, that if you have that big a hazard leading to no OS benefit, and that's something that all of us definitely will be interested to see what happens. But always there are people who say that we know the hazard will fall once you stop. We know that that's absolutely true because it is a TKI. And we've seen that and learned it from already the Geftinib and erlotinib trials. When you stopped it, the DFS curves fell down again. And that's why there are people who still think maybe it may be not, maybe they would like to wait for OS data, but OS data is going to take a long time. Just one last question before we move on. Dr. Rudresh,
in this Adura, I'm Rudresh. In this Adura, I think the type of recurrence or relapse and the number of CNS mets were less. That may be one of the important factors we should look into.
Yes, absolutely agreed. I think that's why you will still have OS benefit, is what I think, because of the difference of the CNS mets, and that's really very dramatic. Dr. Rudresh, last question to you in this part. Do you 1B, would you offer Adura?
Yeah, more than 4 centimeters. Yes.
Yes. Okay. Yeah. So that's one thing everyone keeps saying. 1B, yes, no. We keep hearing that in meetings. So you're yes. That's good. That's great. Okay. So let's move on. I think it's there. It's clearly there in the guidelines, and everyone. Yes.
WhatsApp link
Okay, Dr. Srinivas, we can hear you still.
Sorry for that.
No problem. So I think all of us are looking for further data, but everyone's for osimertinib is in adjuvant, and all of us would use it. 2 and 3, absolutely no doubt. 2 and 3A. 1B, we would definitely consider it, and that's the way the data goes. Any role of neoadjuvant therapy in early stage? So, Dr. Kiran, would you think about neoadjuvant therapy? Do we have the surgical oncology? No, right?
Actually, Dr. Vijay was supposed to join.
No problem.
He was held up in some emergency surgery.
No problem. That's perfectly okay. So Dr. Kiran.
Okay.
Dr. Amit, Dr.
Yes.
Rajiv has joined.
Okay, right. Dr. Rajiv, you can hear us? Okay, let's continue. Dr. Kiran, neoadjuvant in early stage, what are your thoughts? I don't think I'm able to. Okay.
Dr. Rudresh or Dr. Vinayak is there.
Dr. Rudresh, Dr. Vinayak, have you started talking to your patient on neoadjuvant any chance?
I think the talk has to be started by surgeons, because I have not used, actually, frankly speaking, and I don't think any patients is that indication is there. I mean, I'm assuming it is surgery. not CTRT. So I have been using NACT for patients who are like very bulky N2 or something where we planning CTRT. Otherwise, I have not used. I have not got any patients who are that indicated, and I'm sending religiously all patients whenever they're diagnosed with lung cancer to bare minimum 3 tests, biomarkers, or the lung panel which has 12 markers. That is being religiously followed, because end of the day we know that the outcomes are 19% for all comers for the lung cancer. So any time is a good time, but I don't know the studies. I think you can enlighten us.
This neoadjuvant in early stage, you mean to say it is stage less than 3 or stage 1B, 2?
I'm talking of 2 and 3A.
2 and 3.
So basically 2 and 3A.
Yeah, 3A. We given chemotherapy for 3A where our radiation oncologist told they are unable to give radiation, but not for the surgical this thing. Whenever they see it is a bulky mediastinal lymph nodes, they can't able to give in them chemotherapy.
So we have some very exciting data now this time.
Yeah, correct.
So it's all we had phase 2 data earlier, but now we have the phase 3 data of chemo immuno, the 816 data, which everyone's very impressed with. Fat CR rates going from 4% to 25%. But of course, these are non-EGFR mutated patients. But stage 2 and 3A, everyone's very impressed with neoadjuvant. Of course, the debate will be, as Vinayak has rightly said, we have to get our surgeons on the table and then decide, because if our surgeon says it's clearly operable, they operate. Operate, would go for
Dr. Amit, Dr. Rakshit, surgical oncologist, has joined actually the panel.
Okay. Dr. Rakshit, thoughts about would you consider sending patients to a neoadjuvant therapy for stage 2 or 3As, then downstage and operate?
Sir, usually which is operable upfront, we usually go ahead with surgery only, sir.
Right.
Only
so
doubtful
surgery.
mediastinal lymph nodal disease, then we can go for NACTs.
Okay, right. I think that's how everyone conventionally has been doing it and thinking till now. But the 816 data is very impressive. I think we have now seen, we saw the PAT CR, but now we have also seen the DFS curves separating out, and so everyone's kind of interest. But I fully agree with Dr. Rakshit. As of now, if it's operable, clearly everyone wants to go ahead and operate. Dr. Meghla, could I ask you, in your practice, if you're seeing 3B, are you giving directly CTRTs, or are you asking for the medical oncologist to give some induction chemo and then go for CTRT? Do you think there's a difference in that?
Yeah. I think, am I audible?
Yes.
So sometimes we happen to see very bulky primaries. So when you radiate in that setting, you'll be treating a lot of normal lung too. So one major help that neoadjuvant is doing is it definitely, even if there's a partial response, we'll be able to save a lot of normal lung that is treated. So bulky primaries would tempt me more to ask for a neoadjuvant, chemo reduce it, and then give chemo radiation.
Right. I think all of us use quite a lot of some form of anterior chemo in 3Bs, but this whole concept of moving it earlier is what is moving very interesting. Of course, we've seen the neoadjuvant trial ongoing for the new ADAURA trial, so that's something that we still have to wait for and see the results. But that's how the space is moving. So I think the last few minutes, let's talk about stage 4 patient. This is a stage 4 patient, EGFR mutation, L858R. We have all these options. Dr. Rajiv, how do you take this patient forward? What are your thoughts?
So EGFR mutation, L858R.
Yes.
So if feasible, I would go in for option 3, that is third generation TKI, that is osimertinib, if as and when it is feasible. And for L858R, now we have a lot of data with saying that erlotinib along with bevacizumab also is a very good option. So you'll be able to get a longer lease with these patients. But technically, practically, this is what I desire. But practically what happens is I end up putting the patient on gefitinib and chemotherapy and continue it till progression. So that's exactly what has been my practice.
Okay, right. So you use gefitinib chemo maximum, but you would prefer to use osimertinib. right?
Yes,
Dr. Rudresh, for
Yeah, definitely.
this kind of
The first option would be osimertinib. Second option, since the cost is the issue, gefitinib plus chemotherapy. Then I will be continuing with the gefitinib plus pemetrexed maintenance.
Okay, right. Okay, so I think there's a question there. Why not dacometinib? Any thoughts on dacometinib?
Yeah, the toxicity is more in the second generation TKI compared to the first and third generation. And also, I think in the trial they not included the brain mets patient.
Right. Perfect.
So can I just make a point, sir?
Yes. Yes.
Sir, I've used in this very similar situation. I've used dacometinib for 2 patients. Both of them progressed, unfortunately, in the 11th month and 13th month, respectively. And now I'm actually left with nothing else apart from chemotherapy. I did T790M, it came negative. So I tried to look at for data post dacometinib progression. If there is no role for osimertinib also. So I couldn't find any data and trials for that as well. So I felt I was left in the lurch. If I had gone in for osimertinib, possibly it would have given me a longer leash. But now after using daco, I felt like I was like after 11 to 13 months, I got stuck. I would have gotten that amount with my erlotinib itself.
No, I think it's fair enough. 13 months with daco is good enough. You know, you still, the data is 14, 15 months is the median. So I think that's fair enough. You know, I would say we believe it's slightly better, but again toxicity is much more.
Yeah.
I believe toxicity of daco is really more compared to the first generations, and that's what worries us a lot when we use it in practice. And of course, what you rightly said, you know, we could always Aussie starting. We know we're going to get the longest PFS. So that's the way even when we take it further. So I think so all of us are very impressed with the PFS and the OS data of Flora, and as this was already discussed and the real world situations were also discussed. Question is, both mutations, your choices are the same, or do you sometimes vary according to the mutation type? Rudresh?
For 19 and 21, I don't think it makes difference, but Exon 20 mutation, yes, because it is bit resistant to the TKIs. I think where second generation TKI afatinib was, I think, tried, but otherwise chemotherapy.
Right. I think I fully agreed. Insertion 20 is a completely different space, totally resistance, and the new drugs have to come in there. But fully agreed. We are 1921. We do see some differences. We keep talking of different drugs a little bit, but eventually osimertinib data is pretty good for both the mutations. But yes, sometimes for 21 we say dacometinib may be a good drug. We sometimes say erlotinib with combination web may be good. Even chemo Jeff may be good. But eventually ease and convenience, osimertinib becomes very easy to use, especially for patients who can afford it easily.
So what's your view on erlotinib plus ramucirumab or bevacizumab, sir? Before L858R, that's what the company people actually promote.
So what happens is the issue again the PFS data is good. There's no doubt about it. But the issue which turns out for us is always you don't have OS data for it. You know, so you don't know if you're going to get, if the OS doesn't come out, then you'll probably think, why did I do that? Because you have clear OS data with osimertinib. So that's why it becomes a little tricky and challenging. Though we do talk about it in that group of patients, maybe we should consider it because that had the maximum PFS. There's no doubt about that.
So like they do that and then shift over to osimertinib after that. When they progress, when they do progress.
Yeah, but then they should have the T790, right? So then again, 60% will just have, the remaining 40 won't have. Some will progress and some may not be able to take it. But yes, these are all fair enough points. I think we have options to choose from, and we weigh the pros and cons and then do the choices. Last question was I think we're running short of time. So last question, let's put this as brain mets. Dr. Mekla, how do you treat patients with brain mets who come to you?
So I will definitely discuss with my medical oncologist as to what the treatment options are available. It depends on whether they're symptomatic upfront or it is an incidentally detected one when they are on follow-up. So something very tiny, a single one picked up on PET, on some kind of systemic therapy, I wouldn't, jump the gun and treat them immediately. I would wait. Probably for somebody who is symptomatic, very large, causing a lot of edema, midline shift, then I would straight away take them for whole brain radiation. Something in between, who have responded well in the primary, in the elsewhere, and who have limited like 1 to 3 brain mets, maybe you could think of SRS or SRT in them.
Right. I think our usage of SRT has increased quite a lot now, and lung cancer, we try to get more and more patients into that because their survival is getting so long. So I would definitely agree with you. My only thought is I'm never able to define what number should we do SRT for, because the people, though they say less than 4, but
yeah, in the West, they don't have a number, 10, 15, 20, they do SRS. But I think ideally, if you can maintain the dose to the normal brain, it can only tolerate some amount of dose when you're doing SRS. So if you can restrict that very well, then actually there is no number limit. But somebody who would benefit probably would be, I can't remember any data or any phase 3 trials for this, but 1 to 3 would be good, I think.
Right. Agreed, fully agreed. So I think all of us agree on it. So I think we're running short of time. Let's make this as a conclusion remark. Brain mets, there is absolutely no doubt. I'm sure I'll answer for all the medical oncologists. All of us will jump to osimertinib. That's one place where we don't choose between the options, is because if our patients can afford osimertinib, we say that has the best brain penetration, and we would always prefer it. SRS, if possible, do SRS and continue osimertinib. Sometimes give osimertinib and wait for some time and see what happens. But we have seen how osimertinib usage has changed the way we manage patients with EGFR mutation positive lung cancer. So with this, I would thank all the panelists. Thank you for the excellent discussion. Thank you, Dr. Srinivas.
Thanks, Dr. Amit.
So we always love hearing you, sir. It was an excellent
Thanks, Amit, sir.
excellent moderation. Thanks for coming. I thank you, sir, for the excellent presentation. I thank panelists, Dr. Rudresh, Dr. Rajiv, Dr. Kiran, Dr. Meghla, Dr. Rakshit for joining the discussion. So now we'll move on to the next session, or Novartis sponsored session, role of serotinib in ALK positive metastatic non-small cell lung cancer. I welcome Dr. Harish. He's a consultant medical oncologist at Site Care Hospital. Harish, are you there?
Yeah, I'll start sharing. Okay, good evening, everyone. Thanks, Dr. Srinivas, for giving me this opportunity. We are running behind time. I'll just try to finish my task. So, we have heard so many options regarding the EGFR mutations and ever expanding list for post-osimertinib progression as well. So, we are reaching new points there. ALK was a relatively late comer as compared to EGFR mutations, but if you see the number of drugs that have been in this space, it's quite huge. And in fact, I would say progression-free survival of ALK mutation much higher than EGFR mutation. So serotinib is one of the medicines about which presenting in my next few slides. As you all know, ALK forms about 7% of the lung carcinoma. There are a variety of techniques to identify ALK. As of now, NGS is probably most widely used and gives a comprehensive list of mutations available, and as such, recommended test to be done to identify ALK mutation as according to most of the guidelines and panels. So there is no discussion here. NGS is what we would prefer, and Many companies are now offering they're offering kits to test the NGS-based testing. Now, in the next few slides, I'll discuss about the data regarding seritinib in lung cancers with mutation. This is an ASCENT-4 trial based on which seritinib got approval. Initially, the dose was 750 milligram fasting state when the trial was initially concepted. So this was the trial which had 174 patients each arm, chemotherapy versus seritinib arm. And so this is the difference we are seeing, almost doubling of progression-free survival from around 8 months to more than 16 months seritinib. So based on this trial, there was an approval for seritinib as a choice of treatment in patients with ALK mutation. And in the Asian patient subgroup as well, in fact, the responses were much longer. The median progression-free survival was 26 months compared to 10 months in the this is the ASCENT-8 trial. There were those modifications which were tried. Many patients, mainly in the Asian patients, many sites from even India were contributing to this particular study. So there were 3 arms for randomized: 450 milligram with low fat meat, 600 milligram with low fat meat, and 750 milligram per day in the fasting state. And the primary endpoint was steady state with pharmacokinetic therapy, and overall response rate and duration. Key secondary endpoint. What came out was rather interesting. There was no difference in pharmacokinetics between fed state as well as 750 milligram fasting state. Overall response rates, duration of response, is because the absorption kinetics of serotonin with the food absorption is much better, and even the tolerance goes up because of that. So according to this trial, which is in the Asian, 450 milligram after food seemed to be the best dose, best median free survival, overall response rate, as well as overall survival. The 36-month overall survival is 93%. Yeah. Type of survival we don't see type of lymphomas. Much better profile of metastatic lung cancer with ice mutation than having many curative lymphoma. And another thing about this targeted therapy, as you all know, it's Egfr because it can cross blood-brain barrier. 70% of patients do not have brain diagnosis, but the rate of progression in most of the brain is 60 to 70% of the brain seems to be the first organ which loses the response. And this is where seritinib comes into picture. With brain metastasis, continued response with the use of seritinib as compared to chemo. The difference was almost 50%, 27% with chemotherapy as compared to 72%. So almost tripling of response in intracranial response. So whenever there is an intracranial response, is required, no doubt best overall intracranial responses have been observed most of the time, around 80 to 2% of the time. Disease control has been achieved by 79% chemotherapy now. almost tripling of median progression targeted correction. So this is about chemotherapy versus Residual. Now coming on to other comparison with other ALK inhibitors. The trial where the comparative efficacy of first-time serotonin and serotonin was adjusted indirect comparison with external controls. So with serotonin, we do see around 3 months of the rhizotonin, we see around 3 months improvement in progress. Same is almost double, doubling 8 months to 16 months with the use of serotonin. So, though this is a cross comparison, they were adjusted for other parameters. So the difference is quite obvious. The serotonin seems to be again used higher progression-free survival rhizotonin. Again, coming to overall survival, the hazard ratio is better. I would say the hazard ratio is in the range of 0.76 rhizotonin and here the hazard ratio is 0.73 range, not much difference. I would say. Safety profile, quality of personnel, overall quality of life that received. Time to deterioration and the next cancer is also longer. As we all know, in our clinical practice, serotonin is a reasonably well tolerated medicine. Not to diabetes, we need to have anti-medication. Otherwise, it's affected. As I told already, it's a ALK inhibition. Most exciting molecules in last few years have been ALK. There are various drugs, particularly lorlatinib and brigatinib, which have often the highest survival benefit in the lung cancers. And it all started with crizotinib and moved on to serotinib, ectinib, now lorlatinib and brigatinib. So there is a ever increasing number of medicines. 4 category 1 recommendations: ectinib, brigatinib, lorlatinib, patients with ALK. So we have a set of medicines available. The best outcome is always achieved when if we try to use all of these in an optimum fashion so that the patient has maximum each. So yes, lorlatinib and brigatinib have a superior progression as compared to brigatinib. But if you see the overall progression-free survival for an individual patient, if you see, so I think according to this data, if you see the maximum progression survival for a achieved by sequentially using additional second generation and third generation ALK inhibitors. See this data, clearly see that maximum progression-free survival benefit can be achieved if we use serotinib or electrolytic. Can we achieve all this by using chemotherapy? Probably yes. Most comes towards that. As of now, I would say sequentially each agent seems to have maximum benefit. First generation ALK inhibitors not being used at all. Probably in the future it may come that single agent lorlatinib followed by brigatinib may be the best way to go forward. But as of now, current evidence We use Seritinib, the front line, which gives progression-free survival for 2.5 years, and we still have many patients can receive Lorlatinib. In fact, this has been the practice as well. Many of my patients have received Seritinib or Crizotinib for quite long period of time, 1 to 2 years. We do get again response your third generation as inhibitors. So exciting space, but we need to individualize the treatment. And though there are many good agents available, I think the patient gets derives maximum benefit. Right? We try to sequence each of these when they derive something. So these are the points to consider when we use an ALK inhibitor, which is the best agent, which is the maximum response rates, and have intracranial response rate. Where many of the treatments each medicine is very good in control, which is gives the most rapid response. If we want to use second line, what we use? These are the questions we need to ask ourselves as inhibition. There is a lot of unanswered questions, but Crizotinib or Seritinib have agreed, and they progress as a third generation. That's it. So to conclude, Ascent-4 trial formed as gave us one of the best medicines for ALK inhibition. Seritinib. This was the first was obviously that Crizotinib changed the, but the longest progression achieved with Seritinib. Now we have a better molecule. We don't know how to sequence that, and even the brain. We have enough data. Seritinib in Asian patients. With this, I would like to conclude. Thanks.
Thank you, Dr. Harish, for that excellent presentation. We'll move to the next session, next presentation. Dr. Ravi Tippeswamy, consultant medical oncologist from HCG Bangalore. Over to you, Dr. Ravi.
Yeah, thank you. And I thank Dr. Srinivas for giving this opportunity. Let me share my screen. So, am I audible?
Yes, sir.
Yeah, thanks.
And your slides are visible.
Yeah. So today we will briefly discuss about the role of MET inhibitors, and I thank Dr. Srinivas and Novartis for giving this opportunity. So when we come to MET mutations in NSCLC, as with all other mutations, MET mutations are mutually exclusive to EGFR and ALK. The frequency reported in literature is about 3% of NSCLC adenocarcinoma and of about 5 to 22% for other NSCLC subsets. It is also interesting to note that MET mutations are linked to early stage diagnosis and old age. So when we diagnose MET exon 14 mutation, it is important to know that it is associated with worse survival. So it is not only a predictive marker, but also a prognostic marker. If you see the survival curves, those patients with MET mutation, they have inferior survival. And as with all driver mutation, whenever a patient is having MET exon 14 mutation, the response to immunotherapy is poor. If you see the water plot curves, the response to immune checkpoint inhibitors were low regardless of PD-L1 expression status and the tumor mutation burden. So why we should know about MET inhibitors and why we should do NGS in lung cancer? Because if we do a limited panel, we may not pick these rare mutations. And MET inhibition prolongs the survival in MET mutated stage 4 NSCLC. So if you see, this was a retrospective study. The patients who never received a MET inhibitor, their overall survival was only 8 months, as compared to a patient who received MET inhibitor, where the overall survival was 24.6 months. So capmatinib is a selective MET inhibitor. As compared to other agents, it is the most potent inhibitor against MET exon 14. Coming to the landmark trial, that is geometry mono 1 study. So it was a complicated study. It was a multi-center open labeled phase 2 trial evaluating the efficacy and safety of single agent capmatinib. So patients were advanced lung cancer, stage 3B and stage 4. They should be EGFR wild and ALK negative and MET dysregulation confirmed by a central laboratory, and they should have measurable lesions. So they were divided into various cohorts. So cohort 1, 2, 3 and cohort 4, 5, 6, 7. This cohort 6 and cohort 7 were extension of the cohort 4 and 5. Cohort 1, 2, 3, so they were closed because of inferior or futile results. These cohorts were divided based on the gene copy number. And they were treated with the standard dose of capmatinib, 400 mg BD. So in future, we will talk only regarding cohort 4 and 5 and their extension cohorts. So the main objective of the study was to demonstrate anti-tumor activity, that is the objective response rate for capmatinib. And the secondary objective was to evaluate duration of response with other co-secondary objectives, which included overall survival, safety profile, and pharmacokinetics. So as I told, the cohort 1, 2, 3 were closed because of the futile results. So cohort 4 and cohort 5, the cohort 4 were treated patients and cohort 5 were MET naive patients. The important subgroups to be looked into were those with brain metastasis and the concurrent MET amplification. The majority were adenocarcinoma patients. And in cohort 4, as I told, various lines of chemotherapy were allowed, including immunotherapies. And cohort 5B were treatment naive. Coming to the results, in cohort 4, that is pre-treated patients, they noticed clinically meaningful responses when the patient received MET inhibitor, that is capmatinib. The objective response rate was 40.6 months and the disease control rate was 40.6%, and the disease control rate was almost to the tune of 80%. And when we see the treatment naive patients, the objective response rate was about 70%, and the disease control rate was achieved in about 96% of the patients, which was very high. When we see both the cohorts, that is pre-treated and treatment naive patients, and if you see the water plot curves, the depth of response was good in both the cohorts. Coming to the duration of response, in pre-treated patients, it was 9.7 months, whereas in treatment naive patients, it was crossing almost a year. And PFS in pre-treated patients was around 6 months, and in treatment naive patients, it was around 12.42 months. Coming to swimmer plots for responders, the response was rapid and also it was durable in both the cohorts. Coming to subset of patients, which nowadays we all look into in any stage 3 or stage 4 lung malignancies, that is the brain mets patients. So in this study also, when the patient received capmatinib, it was noticed that they have got good intracranial responses. And the intracranial response were fast and also it was durable. Almost all patients responded. Coming to the tumor shrinkage by MET alteration, so whether it can be various MET alterations or MET mutations, all patients benefited as we see in this water plot curve. So they extended the study and the cohort 4 and 5B, that is pre-treated and treatment naive, and they studied further. The eligibility criteria were similar and the endpoints were similar. So coming to the updated results, so it was similar to the first study. Almost 66.7% patients had good response and 98.3% of the patients had disease control when they received in the first line capmatinib. And also when they received capmatinib in second and third line, the responses and duration of control was similar and statistically significant. Almost 50% of the patients had responses when they received in second line and 40% of the patients had response when they received in third line. So whatever lines the patient had received, whether they were treatment naive or they received in second line or third line, all patients had statistically and clinically meaningful responses and durable responses when they received capmatinib. If you see the median duration of response, when they received in first line, it was almost a year. In second line, it was 8.4 months. And in third line, it was 9.7 months. And even the OS also was statistically and clinically significant in both treatment naive and pre-treated patients. So coming to the tolerance and side effect profile, so majority had good tolerance. The common side effects what the patients had was peripheral edema, some GI symptoms, and raised creatinine levels, which was managed with appropriate dose reductions. So to conclude, the preliminary efficacy results of the expansion study, that is in treatment naive and pre-treated patients, are comparable to those in the early study. The OS is statistically and clinically significant both in treatment naive and pre-treated patients. In treatment naive, the OS was almost the tune of 20.8 months. The side effect profile are manageable with capmatinib based on the updated safety profile. The updated results further confirm that MET exon 14 mutation should be identified and it is a targetable mutation. And with presently we have capmatinib, which is a good drug for the patients who has MET exon 14 mutation. So with this, I will conclude. Thank you.
Thanks, Dr. Ravi, for that excellent presentation. It's such an overwhelming thing that we are getting space in every biomarker-driven thing, and in each biomarker MET exon 14, in each biomarker positivity, we have so many drugs so that patients will get a lot of options for the treatment. I thank again for that excellent presentation. Now we move on to the next session. I welcome Dr. Vijay Agarwal for this session. Role of lorlatinib in ALK positive metastatic non-small cell lung cancer, sponsored by Pfizer. Welcome you, sir. Dr. Vijay Agarwal, over to you, sir.
Thank you. Thank you very much, Dr. Srinivas, for giving me this opportunity to be here today to share my thoughts on lorlatinib and ALK translocated lung cancers. Like you said, I think the field is getting really, really crowded now. The fact that we have more mutations and more number of drugs for each mutations. So can you see my slides and hear me clearly?
Yes, sir. We can hear you.
Thank you. So we're going to talk about the role of lorlatinib in the management of ALK rearranged non-small cell lung cancer, particularly in the first line setting, because exciting new data has come out in the recent past. So we all know about ALK mutation. We've been hearing about it this evening. About 7 to 8% of our patients have ALK translocation, seen when we are routinely testing them upfront. And since the first generation ALK inhibitor was approved in 2012, I think we've come a long way in terms of having approval for second generation ALK inhibitors such as seratinib, alectinib, and brigatinib, and most recently lorlatinib, first approved, which was a third generation, first approved in 2019 for use on progression of earlier generation ALK inhibitors, and most recently last year as first line as well, based on the CROWN study, which we'll look at in a little bit detail. So this international guidelines is adopted from NCCN, and we can see that the preferred category 1 recommendations for ALK translocated lung cancers are alectinib, brigatinib, or lorlatinib. There is absolutely no data to say which is better than the other amongst these three, as all the three drugs have been compared with crizotinib, which is a first generation ALK inhibitor. When we talk about lorlatinib, I think lorlatinib is a competitive ATP binder, highly potent, and a third generation ALK TKI. The important thing about lorlatinib is that it has excellent brain penetration, 75% up to address brain metastasis. Now, this is very, very important because even those patients who've progressed on earlier generation ALK inhibitors see further response both in the brain as well as extracranial when they are giving lorlatinib. That kind of tells us that possibly lorlatinib has a significant role to play in overcoming rarer secondary mutations of ALK translocation, as well as exceedingly better brain penetration. So because of these two reasons, I think there is a rationale for evaluating lorlatinib in the first line setting to kind of either prevent brain mets or have a good control of metastatic brain disease at diagnosis, and also to avoid emergence of rarer secondary ALK mutations or rearrangements. So the CROWN trial, which was first published in 2020 in NEJM after its presentation in ESMO, essentially looked at lorlatinib versus crizotinib, which is a first generation ALK inhibitor in advanced ALK positive lung cancer in the first line setting. This is a phase 3 randomized trial of all patients who had either stage 3B or 4 ALK translocated non-small cell lung cancer with no prior systemic disease for metastatic setting. Patients who were asymptomatically treated or untreated, both brain mets were allowed in this study. Patients had one-to-one randomization, about 300 odd patients, or just shy of 300 patients, 149 in the lorlatinib arm and 147 in the crizotinib arm. Patients were stratified based on the presence or absence of brain metastasis, as well as the ethnicity, Asian or non-Asian. And the primary endpoint was progression-free survival, as evaluated by a blinded independent central review committee. The various other secondary endpoints as well. Look at the baseline characteristics. They were reasonably well balanced across both groups, across various parameters, and that included brain metastasis as well as prior brain radiation. Now, the initial data was published in 2020, was an 18-month follow-up data, and the primary endpoint, like I said, was PFS as evaluated by blinded independent central review committee. And we can see the data. It is the Kaplan-Meier curves are splitting wide apart in favor of lorlatinib. So you have a 78% patient surviving at the end of 12 months in lorlatinib arm versus only 39% in the crizotinib arm. Now the hazard ratio is 0.28. So that is excellent hazard ratio. The median survival in the crizotinib arm was of 9.3 months and not reached in lorlatinib arm. Now it's difficult to kind of compare cross trials, but when you start looking at second generation TKIs such as brigatinib and alectinib, when they were compared with crizotinib in a similar group of patients in terms of the recruitment criteria, their hazard ratios was just shy of 0.5, and this is 0.28. So there's a big difference in the hazard ratio for lorlatinib, possibly suggesting that maybe lorlatinib is more effective, but nevertheless, we need head-to-head trial comparison data. When you look at the progression-free survival based on subgroup analysis, I think the benefit is seen across all subgroup analysis, whether the patient were Asian, non-Asian, presence of brain mets or absence of brain mets, performance status, sex, age, smoking status, or thereof. So and all the hazard ratios were excellent across all subgroup analysis. When you look at overall survival, clearly 76% of the patients on lorlatinib responded to treatment as opposed to 58% of the crizotinib arm. But what was quite interesting is that there were 4 complete responders in those patients who received lorlatinib and 0 complete responders in those patients who received crizotinib. When you look at duration of response, it was not reached in the lorlatinib arm versus 11 months in the crizotinib arm. Now, one of the most important parameter in which lorlatinib has always been evaluated has been in terms of controlling of brain mets. So we know that about 30 to 40% of AL-translocated lung cancer patients have brain mets at presentation. So when you're looking at overall response, about 66% of the patients with measurable as well as non-measurable brain metastasis at baseline responded to lorlatinib as opposed to only 20% with crizotinib. And when we evaluated patients with measurable brain lesions only, about the response rates went up to 82% in lorlatinib as opposed to 23% in crizotinib. So excellent intracranial response seen by lorlatinib. Now, when you look at intracranial time to progression, you can see that lorlatinib is essentially a flat line and not reached. And I think it won't be reached for a very, very long time with that level, that kind of curves that we've been seeing, as opposed to 16 months with crizotinib. Now, when we look at hazard ratio, the hazard ratio is 0.07. So this is not a p-value. P-value is 0.001. With the hazard ratio, we don't see such hazard ratios in most of the targeted therapies that we've come across, irrespective of what tumor types and what drugs we're using at. But a 0.07 hazard ratio is excellent. Overall survival, it's too early to tell. It's only been 18 months. And in both the groups, lorlatinib as well as crizotinib, I think the median survival has not been reached at the time of this presentation. When you look at safety, I think there was no unusual side effects that came out in first-line treatment because the treatments were for much longer as opposed to when lorlatinib was given in second-line setting. The number of patients which went to permanent discontinuation because of toxicity was 7% in lorlatinib and 9% in crizotinib. Slightly more grade 3-4 side effects in lorlatinib, which is 72%, as opposed to 56% in crizotinib. And I think it has a very unusual pattern of side effects that we normally don't see with TKIs. And they were basically centered around high cholesterol and triglyceride levels in the blood. That is something that we should routinely be checking in all our patients who are on lorlatinib. We should be doing a lipid profile on a regular basis. The others being edema and increase in weight as well as peripheral neuropathy. So these are some things that we have to keep in mind when we are giving patients lorlatinib. Quality of life was better, especially towards the end, in those patients who received lorlatinib as opposed to crizotinib. This was based on the ERTC QLQ-C30 questionnaire. Now, fairly recently, a few months ago, the 36-month follow-up data was presented as a poster. And when we look at the primary endpoint, which is PFS, based on as assessed by blinded independent central review committee, we see a similar data that we saw with the 18-month follow-up, where the crizotinib median survival was 9.3 months versus still not reached in lorlatinib arm with a hazard ratio of 0.27, which is similar to 0.28, which we saw in 18-month follow-up. When you look at the subgroup analysis, and no significant change there. Again, all in favor of lorlatinib arm. And when we look at patients with brain mets as well as without brain mets, the benefit is seen across both the groups of patients, with the hazard ratio with brain mets being 0.21 and without brain mets being 0.29. And when we look at median progression-free survival, when evaluated by assessing a baseline brain metastasis, it was 7.3 months in the crizotinib arm and not reached in the lorlatinib arm. Again, the hazard ratio being maintained at 0.1. It was 0.07 in the 18-month follow-up, and it's 0.1 in this study. And in those patients where patients did not have brain mets and they were evaluating intracranial progression-free survival, the hazard ratio was ridiculously low at 0.02. So we know that lorlatinib is very effective in treating brain mets as well as in preventing brain mets when given upfront in patients with ALK-translocated lung cancer. So when we compare, when we look at the overall progression-free survival and response rates between lorlatinib and crizotinib, I think lorlatinib is better across all parameters, whether it's response rates, intention to treat population, or in the presence of brain mets, or without brain mets. I think the benefit is seen across all groups of patients. When we look at summary of adverse events, slightly more adverse events in terms of grade 3 and 4 in the lorlatinib arm as opposed to crizotinib arm, but not any untoward toxicities that we were not aware of prior to this trial. Again, when we're looking at a 3-year follow-up, the toxicity pattern remains the same, which was hypercholesterolemia, hypertriglyceridemia, peripheral neuropathy, and edema. These are some things that we need to watch out for when we are giving patients lorlatinib. So when we're comparing 18-month versus 36-month follow-up data on the CROWN trial for lorlatinib, we can see that the progression-free hazard ratio is maintained at 0.27, 0.28, 0.27. Response rates are similar. Time to intracranial progression is similar, and so are the response rates in and outside the brain. And so we know the patients who do respond to lorlatinib are likely to have a long-lasting response. So both the efficacy and safety of lorlatinib was maintained at 36-month follow-up as well. So to conclude, I think lorlatinib is a fantastic drug. It is effective in prevention of secondary or tertiary resistance to second-generation TKIs, and when given as first line, we're likely to see a prolonged PFS benefit, which at 36 months is still not reached. Again, excellent intracranial activity, both in terms of prevention as well as treatment. So certainly, I think we should really consider lorlatinib as first-line therapy in all our patients with ALK-translocated lung cancers. Thank you. That is it for me.
Thank you, Dr. Vijay, for that excellent presentation. You have made it very, very clear what is the benefit of third-generation ALK inhibitors, especially if the patient has brain mets. The things are very, very clear now. This is something like what we use a dasatinib or something like in CML in upfront. What is the benefit we are going to see? Something third-generation drugs they are more potent, they are more effective. I totally agree with you, and the data we have a strong data to show that. Thanks for that excellent presentation, Dr. Vijay.
Thank you.
We'll move on to the next session. I welcome Dr. Guru Prasad, who is a senior consultant medical oncologist in Mangalore. Dr. Guru Prasad, are you there?
Yes, Srinivas. Hi.
Hi.
I'm there.
I welcome Dr. Sandeep Ganguly for this presentation on Crystal 1 and Chrysalis 2, the wonderful 2 abstracts which were presented in this ASCO 2022. Over to you, Dr. Sandeep.
Thank you, Dr. Srinivas, for inviting me for this excellent webinar. So I will be speaking about 2 abstracts. So one is the Crystal 1 and another is the Chrysalis. The Crystal 1 is the activity and safety of the adagrasib in patients with advanced metastatic non-small cell lung cancer harboring the KRAS G12C mutation. Initially, we did not have any target, but now we have found some targets to target this molecularly driven subtype of lung cancer. So, well, it is a oncogenic driver, occurs in 14% of patients, mainly with adenocarcinoma. And majority of around 1/2 of the patients have a CNS metastasis. So they presented as a baseline CNS met. And adagrasib is a covalent inhibitor, which has a long half-life and the dose-dependent pharmacokinetic and the CNS penetration. And in the initial phase 1, phase B trial, the overall response rate was 50%, with the median PFS was 11 months, which was quite amazing. And it has demonstrated a CNS penetration and CNS tumor regression in preclinical models also. And this clinical activity with this drug has been done in patients with the basket trial, like KRAS G12C mutated solid tumors like colorectal, ovarian, and endometrial cancers. So Crystal-1 was a phase 2 cohort 8 study design. The eligibility criteria was a non-small cell lung cancer with a RAS G12C mutation, unresectable or metastatic disease. Prior treatment with a PD-L1 or inhibitor was allowed, and they should have a treated stable CNS metastasis. And the patients were given adagrasib 600 mg BD. It comes in a capsule and a fasting state. The primary objective was overall response rate. The secondary endpoint was duration of response. And this data was registrational phase 2 evaluating the efficacy of this thing. So coming to the demographic and baseline characteristics, median age was 64, majority of the patient has a PS1. As expected, KRAS mutation is mainly present in the smokers, so 86%, 96% in the smokers. Majority of the patient had 40% had prior one line of therapy, and metastasis was present mainly in the bone. And the overall objective response rate was 48, which was the 43%, and the best overall response rate, which was clinical complete response, was 1%. Partial response was 42. Stable disease was 37. So the clinical benefit ratio was around 80%. 5% had a disease progression baseline, during the first interim assessment. And at the time of this study, the 15% of the patients did not have any response assessment were done. And this is the waterfall plot, which shows that there is a marked response, marked shrinkage in the tumor dimension from the baseline. And response were deep in 75% of the responders, achieving more than 50% tumor reduction. And the median time to tumor progression was median time to response was 1.4 months. Median duration of response was around 8.5 months, and treatment is ongoing around 50% of the patients. And this is a premature Kaplan-Meier graph showing the survival. The median PFS was 6.5 months in this study cohort. And the overall survival, the median overall survival was 12.6 months. And the 6-month OS was 71%, 12-month OS was 51%. This is also quite, this data is very encouraging, because in the second line with the standard chemotherapy, the median OS ranges from 7 to 8 months. But here the patients have a OS of 12.6 months. And this is the all comers after failure of one line. Like here, first line, second line, and third line, all 3 comers have been included. And this study shows that most of the patients have a baseline benefit because the numbers is very small, so it has crossed the midline. And now coming to the CNS metastasis, the intracranial response rate was 33%, and 15% of the patients had a complete response. Patients with a non-target lesion had a 21% complete response, and the duration of control of response was 85%. So again, it shows that it has a marked CNS activity also. And the median intracranial PFS was 5.4 months. And this is the adagrasib previously treated patients pre-specified correlative analysis. The other mutational analysis, they have shown that the benefit is there. And even in patients who have a PD-L1 expression, like they're stratified based on the PD-L1 expression, like PD-L1 less than 1, 1 to 49 or more than 50, the benefit is still there, like it's around 40, ranges from around mid 40%. Now coming to the side effect, majority of the patient had the grade 1 to grade 2 treatment-related side effects. As expected, the most common is diarrhea and nausea, vomiting. They were grade 2 treatment-related. One was a cardiac failure and the pulmonary hemorrhage. Treatment discontinuation was done in 50% of the patients, and 61% had a dose interruption. And discontinuation was done only in 7% of the patients. So it looks like that the standard 600 mg BD may not be the standard dose for the overall population, for the standard population. So we have to, I think, use the modified dose, but let the phase 3 trial results come out. So conclusion in this registration phase 2, adagrasib demonstrated promising clinical activity as well as a manageable safety profile. Based on this data, it has been accepted and under review. A confirmatory phase 3 study is evaluating adagrasib versus docetaxel in previously treated patients with KRAS G12C mutant non-small cell lung cancer is going. And it has demonstrated response across 9 tumor types. So obviously it's a beneficial drug. And this was published in the NEJM simultaneously at the time of presentation in the ASCO. So my second abstract is the amivantamab and lazertinib in patients with EGFR mutant non-small cell lung cancer after progression on osimertinib and platinum-based chemotherapy. This is the updated results from the Chrysalis 2 trial. Well, what is first we have to know what is amivantamab and the lazertinib. Amivantamab is a EGFR MET bispecific antibody with an immune cell directed activity. And the lazertinib is a new highly selective brain penetrant third generation EGFR TKI, which has efficacy not only in activating EGFR mutations, but also in T790M and CNS disease. And these preclinical studies have shown demonstrated in anti-tumor activity. And patients, the initial study has shown that patients who progressed on osimertinib but were chemotherapy naive, the overall response rate was 36%, with a median duration was 9.6 months. And this Chrysalis 2 was the analyze the combination of these two drugs in EGFR mutant non-small cell lung cancer who have failed all standard of care like osimertinib and platinum-based therapy. So this is in third line setting. Well, it has a dose expansion cohort. One was the cohort A, post osimertinib and platinum-based therapy. Cohort B, EGFR exon 20, we were a part of the trial. Cohort C, uncommon mutation. This trial is another cohort. And right now, this cohort is ongoing in India also. We are a part of this study. The cohort B, like for exon 19, del 19 or L858R, post osimertinib failure, chemotherapy naive. The combination of chemotherapy with amivantamab and lazertinib is going on. And the primary endpoint was overall response rate, duration of response, clinical benefit rate, PFS, OS, adverse events. And here they have presented the safety and efficacy results of amivantamab and lazertinib combination in this cohort A. Well, the baseline characteristics, the median age was 61 years. 22 patients had 41% of the patient had a baseline brain met, with 22% had a treated, and the median number of therapy was 3. Prior therapy was osimertinib chemotherapy in 23. First and second generation osimertinib platinum based was 67, and heavily pretreated was 35. Anti-tumor activity, the overall response rate was 33%. The median duration of response was 9.6 months. Majority of the patient had a partial response and the stable disease. The clinical benefit ratio was 57%. And the investigator-associated overall response was 28%. And the median PFS was 5.1 months. The median OS was 14.8 months, quite encouraging. And this is the forest plot, is showing the benefit in most of the subjects. Coming to the waterfall plot, again, there is a very marked response, as we can see. Like overall response rate was 21. Even in heavily pretreated patients, they have a 1/3 of the patients had a response to therapy. So quite good. Again, the change in the from the baseline, the size of the diameter of the baseline, again it has shown a marked response. Now coming to the CNS activity, it's a retrospective exploratory CNS analysis. Complete clearance was seen in 26, non-CR, non-PR was 74, and even patients who had a brain metastasis, there is a response, as we can see in one of the patients also. So safety profile, the most common side effect is lots of skin rash, skin reaction. We have to tell them to use sunscreen, avoid sunlight, direct sunlight exposure. That's the main concern because there is a much more incidence of rash, dermatitis, paronychia, and all. MATE related, because of the inhibition, they can have hypoalbuminemia, which can lead to peripheral edema. Other side effects like infusion-related reactions, liver enzymes, and all, which is commonly seen with other EGFR inhibitors also. Mainly was a grade 1 to grade 2. Dose interruption was dose interruption, reduction, and discontinuation was seen in 35, 9, and 7%. Pneumonitis was seen in 7% of the patients, no death. Safety profile was consistent. So, conclusion, so there is a demonstrated anti-tumor activity in patients with EGFR mutant non-small cell lung cancer. Activity is comparable to that previously reported post-osimertinib chemotherapy name. Safety is consistent with the prior reports. And among a population that has exhausted standard of care, we can give this therapy. And the Mariposa and Mariposa 2 are ongoing phase 3 trials, which are ongoing. And amivantamab monotherapy is going to be was presented in ASCO 2022. So I think I will conclude and I'll stop. I'll give it to the organizer. Thank you.
Thanks, Dr. Sandeep, for that excellent presentation. Dr. Guru.
It was an excellent presentation, Dr. Sandeep. Yeah, 2 drugs, because KRAS forms such a big chunk of the mutations which we see, and we have no treatment for it. Hopefully, we'll have more specific treatment because the trials which you showed had only 5% Indian population, and it was a phase 2 trial. So we'll be eagerly waiting for a phase 3 trial. And the other drugs which you said, post-osimertinib is also a good setting where we don't know what to do. And I think a new drug coming there into the picture makes a huge, amivantamab makes a huge thing because it is predominantly from the Chinese setting. So the cost will be much lesser than the osimertinib is what we feel. So yeah, the combination with another drug, yeah, hopefully we'll have another drug coming into it. And I think mobocertinib is also waiting in the line. I think that is another drug which is given post osimertinib, mobocertinib. So thank you, Sandeep. It's nice to hear your voice. I think it's been more than 10 years. We remember the Kidwai days. Srinivas, and and listening to you for all sorts of very you're always well informed, Sandeep. Thank you.
That is
Sandeep.
the whole essence of doing these kind of scientific meetings, inviting all friends, colleagues, teachers, students, juniors. So it's a scientific extravaganza, like a lot of things come out, a lot of good presentations, a lot of your thoughts. What next? So that's wonderfully addressed by Dr. Sandeep. I thank him. Dr. Guru, that was a very valid input. Next,
thank you, Srinivas Guru.
Thank you so much. We'll move to the next session, immunotherapy in non-small cell lung cancer. I welcome Dr. Aditya Murali, consultant medical oncologist in Aster CMI, Bangalore. This session is sponsored by BMS. Dr. Aditya, over to you.
Thanks, Dr. Srinivas. If I can request the organizers to kindly share my slides and sort of, taking the spirit of the discussion from Dr. Srinivas going forward. The biggest achievement that Dr. Srinivas and the team has done for this meet is that, ASCO happened so recently, and he's been able to put such a fantastic program together, which definitely helps people like us who've got no connection to the academia world in the past few years, and we get to read all of these new trials and then hopefully bring them into clinical practice. Pooja, can you please share the slides?
Pooja, can you please share the slides? Dr. Aditya slides.
Okay, Fantastic. So over the next 20 to 30 minutes, I would be speaking about the role of dual immuno-oncology therapy in the treatment of first-line metastatic non-small cell lung cancer. Next slide, please. The initial part of the presentation would focus on what is immune cycle, how can we target this with immune checkpoint inhibitors, and subsequently I would discuss the pivotal trials using the combination of Opdita and Yervoy in first line metastatic non-small cell lung cancer. Next slide, please. So in India, approximately 66% of all non-small cell lung cancer patients are diagnosed at stage 4 with 5-year survival rates of about 5%. Our group alone at ADR did a study which we published in JGO about 7-8 years back, and the numbers are actually higher than this. At least, I mean, I'm sure Dr. Srinivas would also vouch for this. But the number of, let's say, if we see 100 lung cancer patients in a year, at least 80 plus would be in stage 4. That is how late we pick up this disease, and unfortunately this leads to a huge unmet need, and this translates into the need for a highly effective alternate therapy which can improve the depth and the duration of response with a potential for further increase in long-term survival. Next slide, please. So this whole talk is going to be about the introduction of a dual IO regimen in first-line metastatic non-small cell lung cancer. The dual IO based regimen has been approved now as a first-line agent in the treatment of metastatic non-small cell lung cancer. And the two pivotal trials which led to this approval are the Checkmate 227 trial. This was for patients with PD-L1 more than 1%, and this just looked at the dual IO combination, and the Checkmate 9L8 trial, which looked at a combination of the dual IO along with some chemotherapy in the first 2 cycles. Next slide, please. So I'll spend a little bit of time on this slide. This slide talks about the immune cycle and the role of the immune cycle in the whole cancerogenesis profile. Essentially, when we give a patient some kind of a chemotherapy or a radiation or a target therapy, this leads to release of tumor antigens. These tumor antigens get updated and get presented to the immune system. The tumor antigen presentation leads to T cell priming and activation, and it is at this critical stage, which means at very early in the immune cycle, we have a drug which is going to target, and this is the anti-CTLA4 monoclonal antibody. So what this does is that it acts earlier in the immune response. It both upregulates T cell activity and helps create memory T cells. Subsequent to this, in the immune cycle moving forward, the T cells get trafficked to the tumor and lead to T cell tumor infiltration. This then gets recognized. Then the recognition of cancer cells happen by the T cells, and finally at this stage, when the killing of cancer cells happens, this is where the anti-PD-1 and the anti-PD-L1 agents come into the picture. So essentially here, all the medications which we are using in the immuno-oncology space act almost at the last part of the immune cycle, almost in the effector phase. If we try to use a dual IO combination, we have something which acts in the earlier part of the cycle, and that's what my next slide is going to be. Next slide. So we have 2 drugs in the dual IO combination. One is the ipilimumab, which is an anti-CTLA4 agent. This basically enables adaptation to evolving tumor. The dendritic cell T cell interaction happens in the lymph node. This promotes emergence of memory T cells and causes compensatory increase in tumor PD-L1. So CTLA4 is basically expressed on T cells and it inhibits T cell activation. So if we are going to start at the initial phase and inhibit the CTLA4 inhibition, then this leads to the effector phase of the immune cycle, wherein nivolumab, which is an anti-PD-1 agent, this restores the anti-tumor T cell function. Hence, we have got action at 2 separate phases of the immune cycle. Next slide, please. And because we have separate phase molecules which act at separate phases, they lead to potentially synergistic combinations. So here we have one agent, which is the CTLA4 agent, which blocks the CTLA4 pathway at the periphery. This leads to activation of the cytokines, lysis proliferation, and migration to the tumor. Then we have another molecule which acts at the tumor microenvironment level, blocks the PD-1 pathway. This is done by nivolumab, and this blockade results in target cell killing and inhibition of AKT protein kinase B activation by preventing the PI3K activation. So ipilimumab with nivolumab can potentially have a synergistic action. Next slide, please. So Opdita, which is nivolumab, and Yervoy, which is ipilimumab, versus platinum doublet chemotherapy as the first line treatment for advanced non-small cell lung cancer. So this was the idea behind the Checkmate 227 trial. Checkmate 227 trial has 6 parts, and I would be discussing the part 1 for now. This is the 4-year update which I would be discussing. Next slide, please. So in the first trial, this study design looked at, including patients who had stage 4 or recurrent non-small cell lung cancer, but essentially patients should not have had any prior systemic therapy. The patient should not have had any sensitizing EGFR or ALK4 alterations. Obviously, patients in this trial were ECOG PS1 or 2, and I think I will highlight this a little bit because in our mind, if we try to conceive a particular subset of patients where we don't want to use chemotherapy, we might want to think that we would want to use this in patients who are ECOG PS2 or maybe a little bit more than that. But this trial included only the PS0 or PS1 patients. The trial mandated that patients should have a PDL1 expression of more than 1%, and this was done on the 28-8 antibody clone, the DACO 28-8 antibody clone, which I don't think we are using in India, but we know as per the blueprint trial that there is fairly good cross variable acceptability when we use the other antibody clones. So the patients with untreated brain metastasis, carcinomatous meningitis, and active autoimmune disease were excluded in this trial, and patients were randomized 1:1 to a combination of nivolumab at 3 mg QT weekly along with ipilimumab. And the important thing here is that the important thing here is that the dose of ipilimumab which was used in this trial was 1 milligram per kg given every 6 weeks. The treatment, this was compared against the standard of care arm, which was a platinum doublet therapy. The treatment was continued until disease progression or unacceptable toxicity up to nearly 24 months. The biggest trial was that it looked at a primary endpoint of overall survival. Now, whenever we design trials in stage 4 diseases, especially stage 4 lung cancer, overwhelming majority of them are having PFS as a primary endpoint. Here is a trial, which means that the trial investigators were so certain that the patients will do well that they picked overall survival as the primary endpoint for this trial. So for Checkmate 227, the median follow-up was nearly 54.8 months, which is the longest median follow-up of any IO-based combination in a phase 3 trial. Next slide, please. So this looks at the characteristics of baseline characteristics of all the patients. The median age was about 65. I think the important thing I want to highlight in this slide is that overwhelming majority of the patients were current or former smokers, and we know that patients who are either current or former smokers tend to have a higher expression of PDL1. There was no problems in terms of including patients with a squamous or a non-squamous histology. That's one. Very importantly, about 50% of the patients had a PDL1 expression of 1 to 49%, and another 50% of the patients had a PDL1 of more than 50%. So they were fairly well divided. Next slide, please. So this slide basically talks about all patients and the combination of Opdita along with Yervoy in patients with PDL1 more than 1% offers durable and long-term survival benefit with nearly 30% of the patients alive at 4 years. And let me repeat, we are talking about stage 4 lung cancer. As early as 7-8 years back, we were talking about 4-5 year survivals of just 5%. And here we have a trial which is showing that nearly 30% of the patients can potentially be alive at 4 years if they have a PDL1 percentage of more than 1%. So the experimental arm of Nivo with EP versus chemo showed a hazard ratio of 0.76, and at 3 years, the overall 3 years, at 3 years, about 1/3 of the patients who were on the Nivo EP arm were alive, and at 4 years, again 29% of the patients were alive. Quite significantly, if you analyze the trial a little more deeply, probably the trial chose a fairly good subset, or patients with a good disease biology, because even in patients who did not receive any targeted or immunotherapy, 18% of the patients were alive at 4 years. And even having a fifth of our patients alive at 4 years with stage 4 non-small cell lung cancer, if they're receiving only some chemo or the other, is a fairly good outcome. So this trial actually picked up patients with a good disease biology, and that could be one thing which could be discussed about. Next slide, please. When we try to divide across histologies, it did not matter whether the patient had a squamous histology or a non-squamous histology. Patient had superior overall survival. In patients with a non-squamous histology, patients who went on the Nivo EP arm had a median overall survival of about 19.4 months, and patients who went on the chemo arm had a median OS of about 17.2 months. Especially, we know that patients with squamous cell carcinoma don't do that well with chemotherapy. And in this subset of patients, if they went on the Nivo EP arm, the median overall survival was 14.8 with the median OS of the chemo of 9.2. And you can see here that the hazard ratio of 0.68 was fairly significant. So if we look at the non-squamous arm, the hazard of about 0.81 is not, it's still statistically significant, but not too great. But if we look at the squamous arm, definitely the hazard ratio here is very significant. Next slide, please. Among patients who went on Opdita with Yervoy combination, responders at the 6-month mark, and let me spend a little bit of time on this. How do we predict whether a patient would do well or not? So I think a good time point for us to assess if we are using the dual IO combination in first line is to look at patients who are responding at the 6-month mark. So if we have achieved some kind of a response at the 6-month mark, then nearly 70% of the patients were alive at the 3.5-year mark. So I think if a patient tomorrow or on Monday morning asks in the clinic, doc, what are my chances of doing well for 3 years or 4 years, then I think a sensible answer would be to tell them that let us start off with a particular treatment protocol, wait for about 6 months, and if you're responding at 6 months, this gives us a good idea as to how well you will do in a long term. And this type of analysis actually avoids intruding bias due to the OS estimation from randomization by subsequently observed response categories during the study. Next slide, please. So this slide talks about the overall response rates and PFS, and see, the caveat here is that progression-free survival was not one of the primary endpoints. And I think this particular result did surprise many of the medical oncologists and did disappoint them quite a bit, because if we looked at median PFS, and again I reiterate, median PFS was the primary endpoint across majority of the stage 4 trials. In the Nivo EP combination, even if the patient had a PDL1 of more than 1%, the median PFS was just about 5.1 months. And in fact, patients who went on the chemo arm had a median PFS of 5.6 months. So this does tell us one more thing, that we are not yet there wherein we can confidently tell that PDL1 expression of more than 1% is the most important biomarker, because if the median PFS here is so less and compared to the chemo, it does make us doubt a little bit of things, and this was statistically significant. The hazard here was 0.81. However, when we look at the 4-year PFS rates, about 15% of the patients had a progression-free survival, which means this trial, the 227 trial, mandated that patients stop the dual IO after 24 months. So even after stopping after 24 months, if we look at the 4-year PFS, this was about 15%. So that is what is quite surprising. And I think in the previous slide, as I told you, if you are able to identify the responders at the 6-month mark, That will give us a very good idea how well our patient is going to do in the next 2, 3, 4 years. Next slide, please. This slide talks about the duration of response by a blinded independent reviewing committee, and about 34% of the patients who went on the Epdata versus with Yervoy arm maintained response at the 4-year mark. So if you look at the 4-year mark, patients who went on the dual IO combination, 34% of them maintained a response as compared to about 7% who were only on the chemo arm. Next slide, please. This slide talks about the safety profile, and I think it's very important for us to look at this because, as I repeated or as I said earlier in my talk, our mind sort of tries to tell that okay, this patient may not have a very good performance status, and I might want to potentially omit chemo and use the dual IO combination. But we need to know that even if we do use the dual IO combination, there is a fairly good chance that there might be adverse events, and although they are unique as compared to chemo, the rates of grade 3 4 adverse events are quite are fairly there. All in all, nearly 70% plus grade 3 4 adverse events were seen even in the dual IO arm. But what we cannot ignore is the fact that the adverse event profile was much more in the chemo arm as compared to the dual IO arm. Next slide, please. So efficacy in patients who discontinued the dual IO due to treatment-related adverse events. So this is, I mean, this slide basically also helps us counsel the patient in the clinic. So let's say tomorrow we offer a patient that yes, okay, you don't want chemotherapy, we'll give you a dual IO. If the patient asks, doc, if I have a immune-related adverse event, how am I going to do if I stop the dual IO? Is it really going to make a difference? And wouldn't be better if we just start off chemo because we know what kind of adverse events are there. But if a patient had to discontinue the dual IO due to treatment and adverse event, this population showed a median overall survival of about 30.6 months. So even in spite of discontinuation, the median OS was far better. The 4-year overall survival rate was nearly 45%, which just goes to show that if a patient has adverse events with the IO, there's a chance that they might also respond much better to the IO, and then the median overall survival is quite significant. Next slide, please. So NCCN has a category 1 recommendation. When we talk about patients who have metastatic non-small cell lung cancer with a PD-L1 percentage of more than 1% in the first line for the dual IO combination of nivolumab with ipilimumab as a first line option. Next slide, please. So this slide talks about the summary of the Checkmate 227 trial. The 4-year survival, 4-year overall survival for patients who were on the dual IO arm was about 29% as compared to 18% in the PDL1 more than 1% subset. Among patients with PDL1 more than 1%, 70% of the responders are at 6 months in the dual IO arm were alive at 3 years. And I think this is the more important key takeaway for us from the Checkmate 227, and this is what we should be telling our patients in clinical practice. In the post-hoc analysis, the discontinuation of the dual IO due to treatment-related adverse events did not have a negative impact on the long-term benefits seen in all randomized patients, and approximately half of the responders who had a treatment-related adverse event leading to discontinuation maintained their responses for more than 3 years after treatment discontinuation. This dual IO regimen is a novel chemo-sparing first-line treatment option for advanced non-small cell lung cancer. Now, this begs the question, are we at a stage wherein we can sequence our therapies for patients who don't have any driver mutations in metastatic non-small cell lung cancer? I think the time for that has not yet come. That's also primarily because chemo sparing cannot be equivalent to using this combination in poor performance status patients. Next slide, please. So the last part of my talk is going to be on the Checkmate 9L8 trial, which is a 2-year update. This trial basically used a combination of the dual IO along with 2 cycles of platinum-based chemotherapy for patients with first-line non-small cell lung cancer. And the next slide, please. The big rationale for this trial was basically because it could potentially provide rapid disease control while building on the durable overall survival benefit. So in case we have a patient who's got a very high clinical burden, there is always a combination for clinicians, because see, we are comfortable with chemo. I mean, we've been using chemo for more than 10 years now. So we are always comfortable giving chemo because we know that yes, this patient has got a lot of bulky disease in the liver, in the lungs, and I need to debulk the patient as quickly as possible, and IO may not get me there as quickly. So this trial looked at adding chemo only in the first two trials to the dual IO combination. Next slide, please. So again, fairly complicated study design. The key eligibility criteria here was patients who didn't have any driver mutations with stage 4 NSCLC. ECOG PS 0 or 1 was included, and this trial uses stratification of histology. PDL1, patients with PDL1 of less than 1% or more than 1% were also included, and patients are stratified based on the sex. So the experimental arm in this trial was a combination of nivolumab given at a dose of 360 milligrams Q3 weekly, along with ipilimumab given at a dose of 1 milligram per kg given every 6 weekly. This was combined with 2 cycles of platinum doublet chemotherapy, and this arm had about 350 patients. The comparator arm was a 4 cycle of platinum doublet chemotherapy standard of care. The primary endpoint again in this trial was overall survival. So the two key things about this trial was the primary endpoint being overall survival, and this trial evaluated patients regardless of histology or PDL1 expression. So tomorrow, if anyone wants to ask, is there a study or is there data to say that in spite of patients being PDL1 negative, can we combine all the three of our most powerful weapons in the first line? This is that study. Next slide, please. Baseline characteristics were fairly well matched. Interestingly, in this study, about 40% of the patients who were PDL1 negative were included. Again, another 40% of the patients had PDL1 expression about 1 to 49%, and about 20% of the patients had a PDL1 expression of more than 50%. Next slide, please. So the combination of Opdita with Yervoy with 2 cycles of chemotherapy demonstrated a superior overall survival versus chemo only, with a very significant hazards of about 0.72. We can see that at the 2-year mark, nearly 40% of the patients were alive if they went on the dual IO with just the initial 2 cycles of chemotherapy. Next slide, please. 37% of the patients treated with Opdita and Yervoy on the experimental arm were alive at the 2-year mark, and this included patients who were PDL1 less than 1%. So in this very difficult to treat subset, we have one more potential weapon or in our armory. Next slide, please. And if we divide the subgroup into a PDL1 more than 1% and a PDL1 more than 50%, in patients who are PDL1 positive, we expect that the dual IO chemo combination to do far better. At the 2-year mark, 41% of the patients were alive. They went on the dual IO with chemo combination. And if the patient had PDL1 of more than 50%, at the 2-year mark, 45% of the patients were alive. The median overall survival in this subset of patients was nearly about 1.5 years. Next slide, please. This is a fairly busy slide. It basically looks at various subgroups. I think the important thing to note over here is that, if a patient had PDL1 less than 1%, so this is what we keep debating in the clinic every day. Let's if a patient has no driver mutation and PDL1 less than 1%, what is the best that we can do for them? So if a patient in this particular setting went on the dual IO with the chemo combination, they could potentially have a median overall survival of about 1.5 years. Here, the unstratified hazard ratio was a very significant 0.67, and you can see that on the forest plot, everything is fairly significant. Next slide, please. At 2 years, Opdita plus Yervoy, regardless of PD-1 expression or histology, with 2 cycles of chemotherapy, nearly tripled the duration of response with chemotherapy alone. And this is again a very important indicator to say that a combination of 2 IO agents and the chemo doublet does improve the duration of response for patients regardless of histology or PD-L1 expression. Next slide, please. The one thing which is always in the mind of a clinician is if we combine so many agents and you are looking at a combination of 4 molecules here, is there any problem with the safety? Obviously there will be safety issues, but when we look at treatment related adverse events leading to discontinuation in the dual IO chemo arm, it was only about 18%. So it was not too much. It's not like unexpectedly high, and this is fairly expected based on the earlier trials done in patients who already had received dual IO agents. Next slide, please. So efficacy in patients who discontinued dual IO plus chemo due to treatment related adverse events was again maintained, and in this subset the 2-year overall survival was 50% plus. So if even if a patient could receive, let's say, a median dose of about median number of cycles of about 7 cycles, in spite of this we could potentially expect more than half of the patients to be alive at the 2-year mark. Next slide, please. So this slide talks about the majority of the treatment related select adverse events could be resolved through well established management algorithms. I think when the first IO agent was introduced in India, all of us were trying to get a feel for this agent because we have never used this during our training, and this all come in the last few years. But in the last 4-5 years, I think we have gotten fairly good at using this. Ipilimumab, again, it took a lot of study and lot of real world experience to arrive at the dose of ipilimumab. Ipilimumab was initially started at 3 weekly dose, and it was started at 3 mg per kg dose. But when we use this at a dose of 1 milligram per kg given at 6 weeks, again it's fairly well tolerated. Next slide, please. So if we look at the major treatment related adverse events, about 35% of the patients or 40% of the patients had skin toxicity. I think we have to keep in mind the endocrine related toxicity, which also means that if we are using a dual IO combination prior to each cycle of therapy, it is very important for us to look at the thyroid profile, the cortisol levels, because about a quarter of our patients could potentially demonstrate some kind of a endocrine related treatment related adverse event. Next slide, please. This slide basically talks about the other adverse events like anemia, neutropenia, thrombocytopenia. None of them were too new, and this is all in line with what we have seen in previous studies. Next slide, please. So this is my last slide, and I will conclude at this. To summarize the Checkmate 9LA trial, this trial looked at a combination of Opdivo with Yervoy with 2 cycles of chemotherapy in first-line advanced non-small cell lung cancer at 2 years. The overall survival was durable versus chemotherapy, and with a nearly 40% overall survival at 2 years. Benefit was observed across key subgroups, including by PD-L1 expression level and by histology, and there were no new safety signals. So even if we used a 4-drug combination here, the safety signals were not anything new, and about 56% of the responders who had a treatment-related adverse event leading to discontinuation maintained their responses for more than 1 year after treatment discontinuation. So the Checkmate 9LA demonstrated that Opdivo with Yervoy with 2 cycles of chemotherapy should be considered as a new first-line treatment option for advanced non-small cell lung cancer. I thank BMS and Dr. Srinivas for this opportunity, and I'm happy to take any questions. Let's stop here.
Thank you, Dr. Aditya. That is, you have given a very extensive knowledge. I mean, starting from how to prime the T cell in the early cycle of the immune cycle, and what about the late part of the immune cycle, how it works. You just enlighten us actually, and the role of dual IOs, and as you rightly said, 6 months, if the patient is going to do good, he's going to go long. So you have thrown a really good amount of light on this topic. Thanks for that excellent presentation, Dr. Aditya.
Thanks for having me on board, Dr. Srinivas. Thank you very much.
Now I'll quickly move on to the next section. Merck-sponsored session by Dr. Naveen Jairam Anvekar, consultant medical oncologist at Narayana Hospital. He's going to talk on role of tepotinib in Exon 14 skipping mutation in lung cancer. Over to you, Dr. Naveen.
Yeah. Thank you, Srinivas. I thank Dr. Srinivas and Merck for giving me this opportunity. I'll be speaking. Can you see my slides?
No, sir, you need to share your screen.
Naveen, can you share the screen?
Yeah, I had shared.
Green one in the center.
Okay. Now?
Yes.
Yeah, okay.
Yes. Just make it a full screen. Yeah, correct. That's right.
Yeah, I'll be speaking on meeting the unmet needs in MET exon 14 the skipping mutation, this is T-protein. This one on MET exon 14 skipping mutation, it has already been highlighted by Dr. Ravi Tippeswamy. I'm just revising some of the other points. And the MET is this tyrosine kinase receptor for hepatocyte growth factor. And the MET activates downstream signaling pathways that drive essential cellular processes. And the binding of the hepatocyte growth factor leads to activation of the downstream signaling pathways, which lead to cell proliferation, transformation, migration, and tubulogenesis. And it is usually what you call the receptor is lysed by ubiquitination. And MET abnormalities include MET exon 14 skipping mutation, which is seen in this in 3% of lung adenocarcinoma, and also MET gene amplification. And MET exon 14 skipping mutation, it reduces the degradation of the MET protein, causing it to behave as an oncogenic driver. And patients with advanced non-small cell lung cancer with MET exon skipping alteration have a poor prognosis. As you can see in this one diagram, the median overall survival in treatment naive patients with or without MET exon skipping alteration who underwent surgical resection is around 1 year for MET exon positive, and it's around 5.5 years for patients who were MET exon negative. And more than 50% of the patients in either group had an adenocarcinoma history, and more than 80% of the patient in either group had stage 1 or stage 3 disease. And what were our treatment preferences before the availability of the selective MET MET inhibitor? So we usually used to do some 4 markers: EGFR, ALK, ROS, and this one PDL1, and used to treat the patient. And patient who were treated with immunotherapy as a single agent or in combination is associated with low response rate in patients with MET exon skipping this mutation as first line, second line, or third line this treatment. As you can see in this waterfall plot, the what we call progressive disease and stable disease is far higher than this partial response. And in this group, nearly 60% of the patients with MET alterations had very high PDL1 expression. So if you don't do the NGS and just go ahead with this PDL1 level, and if it is MET exon 14 skipping mutation, the response will be very, very poor. And the survival outcomes for patients with non-small cell lung cancer with MET exon 14 skipping alteration, it remains suboptimal with chemotherapy or immunotherapy. And in this one diagram, you can see the median overall survival, the yellow with immunotherapy, which is around 18 months. And with only chemotherapy, it is around 8.5 months. And though in those who have received MET inhibitor, the median overall survival was around 25%, 25 months. And patients with non-small cell lung cancer and MET exon skipping alteration had a significantly improved survival with MET this one TKI inhibitors and versus this one chemotherapy or immunotherapy. With MET inhibitor, the median overall survival was 24.6 months versus 8.1 month versus the other group. So treatment with MET TKI was associated with a significant increase in survival versus those who have not received the MET TKI with a hazard ratio of 0.11, which is very, very significant. And coming to the types of MET inhibitors, the MET inhibitors are usually grouped as type 1 inhibitors, type 2 inhibitors. Type 1 inhibitors, the inhibitors are ATP competitive, binds with the ATP binding site in a U-shaped conformation. And in type 2 inhibitors, the drugs are ATP competitive, binds to the ATP binding site in an extended conformation. Okay, so and also the MET1 inhibitors is divided into MET1A and MET1B. This one crizotinib, which is a multikinase inhibitor, which inhibits ALK, ROS, and MET also, is a type 1A, whereas the tepotinib, capmatinib, and savolitinib and AMG 337 comes under the what is called this one type 1B, and these are MET specific. And the other group where the MET type 2 inhibitors, the drugs are cabozantinib, merasetinib, and glesatinib, and all are not MET specific and are multikinase inhibitors. And the mode of action of the drug, the what you call the mode of action of all this group, the tepotinib, capmatinib, and what you call crizotinib and savolitinib are almost same, with a potency IC ratio of IC50 value of tepotinib of 1.7 nanomole. And MET inhibitor dosing, the long half-life ensures a peak trough variation over 24 hours. So potentially reducing the risk of toxicity at peak and suboptimal inhibition at trough. And this one tepotinib, the T half is approximately 30 hours compared to 6.5 hours with this one capmatinib. And the guidelines recommend MET TKIs for the treatment of patients with non-small cell lung cancer harboring MET exon 14 skipping alterations. And the NCCN guidelines, they recommend targeted treatment with tepotinib or capmatinib as a preferred option for both first line and second line treatment. And crizotinib is recommended under certain circumstances, especially when the patient can't afford both the above drugs. And also it is recommended by ASCO and other guidelines. And this is a phase 2 multicenter trial, the Vision trial of this one tepotinib in patients with non-small cell lung cancer harboring MET alterations. And the patient receives oral tepotinib. This one tepotinib comes as a 250 milligram tablet, 2 tablets this one once daily until disease progression, intolerable toxicity, or withdrawal of the consent. And the key inclusion criteria was stage 3B or stage 4 non-small cell lung cancer, EGFR ALK wild type, and all histologies, and ECOG PS 0 or 1, and the patients with MET exon 14 skipping alterations in the second line, first line, second line, or third line setting. They included cohort 1, where the primary analysis had MET exon skipping mutation, and cohort C, MET exon skipping mutation as a confirmatory analysis. And the study included 275 patients, and of this, half of were treatment naive, and half of them had received this one previously treated. And the selected endpoints were, the primary endpoint was overall response rate. The secondary endpoints were this one duration of response, PFS, OS, and safety. And the Vision was designed with this one clinical practice in mind. And the what you called this one, the biopsy included both tissue biopsy and liquid biopsy. This one reflecting this one clinical practice what we follow. And although this one tissue biopsy is a gold standard, liquid biopsy may be useful in patients for whom this one performing tissue biopsy is not an option. And the protocol defined 3 analysis sets for all endpoints with this one tissue population, biopsy population, liquid biopsy population, and combined population. And most patients were elderly and even older in the first line setting, and half of the patients were male and half had a smoking history, and most patients had adenocarcinoma. And this is a waterfall plot which you can see in this diagram. Over 90% of the patient of treatment naive patients treated with tepotinib experienced tumor shrinkage with a high this one partial response and stable disease. And tepotinib demonstrated excellent efficacy, evidenced by longer duration of response of 32.7 months, median duration of response, and longer PFS of median PFS of around 15.3 months. And based on this study, tepotinib demonstrated robust and lasting efficacy as a first-line treatment in treatment-naive patients with the MET exon 14 skipping non-small cell lung cancer detected by tissue biopsy. And the overall response rate was 54.7%, median duration of response of 32.7% month, and median PFS of 15.3 months, and median overall survival of around 30 months. And the tumor showed consistent sensitivity to tepotinib therapy regardless of the biopsy method. And this overall response rate, as I mentioned, was seen. And even in patients who had brain metastasis, tepotinib showed a durable and robust response with what we call disease control rate of around 76.5% and overall response rate of 52.9 months, and median duration of response in this 9 months. And this MRI image showing patient with the intracranial what we call metastasis, this one brain metastasis, showing an excellent response after 36 weeks of treatment. And the drug has a manageable safety profile across the different patient subgroups, and especially in patients less than 65 years, the grade 3 side effects was around 14.1%, leading to this one treatment permanent discontinuation of the treatment in 6.3% of patients. But as the patient age increases, the what we call this one discontinuation rate increased, and also the side effects. And the drug is available as simple once daily regimen of tepotinib, and fewer discontinuations around 14.1%, and manageable adverse effects, and the low treatment related peripheral edema. The most common side effect of this drug is this peripheral edema, which is seen around 65.6% of the patient, followed by nausea and hypoalbuminemia. And around those patients who had what we call this peripheral edema, they had to go for this reduction of the drug dose, and only 4.3% of the patients discontinued the drug. And to conclude, tepotinib is a simple once daily oral dosing regimen associated with robust efficacy and maintained quality of life, with fulfilling the unmet need, and has an efficacy with overall response rate of 54.5% and more than 90% tumor shrinkage, and median duration of response of 32.4 months. And it's a once daily oral dosing, and you can use both liquid biopsy and tissue biopsy. And the safety, other than this peripheral edema, nausea, and hypoalbuminemia, rest are very small in number. Thank you.
Thanks, Dr. Naveen. That was a very nice presentation. I have thrown light on different drugs, what we need to do. And it's a simple regime, and you have thrown light on toxicity profile on depending on the age. Thanks for that nice presentation. I will move on to the next session. Dr. Samit, I welcome Dr. Samit Purohit for the next session to present his two abstracts. Dr. Samit, over to you. And this session is chaired by Dr. C.N. Patil, sir. Hi, C.N. Patil, sir. Are you there?
Yes, Srinivas.
Welcome you, sir.
Thank you.
Dr. Samit, over to you.
Thank you, Dr. Srinivas, for inviting me on this forum. And as I've been hearing the previous trial data by the previous speakers, it's very encouraging. And I hope the future is good. And we have a good number of drugs available at hand so that we can give better services to our patients. So the first abstract which I'll be presenting is the Cosmic 021. So this, they have tried to emphasize on two cohorts, cohort 7 and cohort 20. And the idea is to use cabozantinib plus atezolizumab in one cohort and cabozantinib alone in the other cohort in patients in advanced non-small cell lung cancer who have been previously treated with immune checkpoint inhibitor. So with the background that we know that cabozantinib is a multi-targeted receptor tyrosine kinase inhibitor, and it has demonstrated efficacy alone or in combination with nivolumab in advanced RCC. And atezolizumab again is an anti-PD-L1 antibody, quite effective. We have used in NSCLC without EGFR and ALK aberrations. So in Cosmic 021 trial, we have tried to see the efficacy in patients who have had previous immune checkpoint inhibitors. In one cohort, cohort 7, we have we'll be seeing the results of cabozantinib plus atezolizumab, and in other cohort, which is cohort 20, we'll be seeing the results of cabozantinib. So this was the study design. And stage 4 non-squamous non-small cell lung cancer patients with radiographic progression on one or more prior ICI for metastatic disease were included, and 2 or less than prior lines of systemic anti-cancer treatment would be have been taken by these patients, and the actionable targetable mutations were excluded. The cohort 7 included cabozantinib at 40 mg per orally daily and atezolizumab at 1200 mg 3 weekly, and cohort 20 had cabozantinib at 60 mg once daily dosing. So tumor assessment was done as per the RECIST 1.1 criteria, and it was assessed every 6 weekly for first year and thereafter every 12 weekly. The primary endpoint was overall response rate, and the secondary endpoint was safety. Exploratory endpoints were duration of response, PFR as per the RECIST, and overall survival. So these were the patient's baseline characteristics, and if we see, these are quite well balanced between both the cohorts. In the combination cohort of cabozantinib and atezolizumab, median age was 67 as compared to 17 cabozantinib. Predominantly male population was there, fit performance status. With respect to the smoking history, close to 68 to 70% of the patients were former smokers. 17% were current smokers and 10% in cabozantinib, and 15 to 16% were never smokers. Again, predominantly adenocarcinoma histology close to 94 to 100%. With respect to PD-L1 status, positivity was seen in 68 to 70% of the patients with both the groups. With respect to tumor sites, predominantly lung disease were in 84 to 87% of the patients, followed by lymph node in 54 to 61, and in decreasing order of frequency, then we had liver, bone, and adrenal metastasis. Prior lines of systemic therapy received were 57, close to 50% in 2 or more lines of therapy received, and 43% in patients who had received 1 line of therapy. Prior platinum was close to 80% of the patients. And with respect to the prior therapy, the recent therapy which was received, ICI alone was in close to 50% of the patients in both the arms. ICI plus chemo in 23% of the patients. Then ICI plus other therapy in close to 5% of the patients, chemotherapy in 16%, and there were others in 4 and 0 respectively. So this is the tumor response. So we'll focus on this cohort, the combination cohort first. So the patients who were in this cohort achieved a disease control rate of 80%. So partial responses were seen in 19% of the patients, and 62% of the patients achieved stable disease. With respect to PD-L1 expression of less than 1, more than 1, and unknown PD-L1 expression, even though the numbers were quite low, the disease control rate was quite comparable, 74%, 80%, 86%, and so were the sub response, like partial, stable. They were quite comparable in between, irrespective of the PD-L1 expression. With respect to the cabozantinib arm, the disease control rate was 65%. 58% patients achieved stable disease, 6% had partial responses, and 19% had progressive disease. So coming to the waterfall plot, again, we could see that 76% of the patients had tumor reduction, and this was close to 69% in patients in the cabozantinib. If you see the change in some of target lesions over time, so this is the combination arm, and median duration of response was 5.8 months in the cabozantinib plus atezolizumab. In the cabozantinib arm, again, the median duration of response was 10.6 months, somewhat higher than the combination arm. So with respect to median PFS, the combination of cabozantinib plus atezolizumab achieved a median PFS of 4.5 months as compared to 3.4 months in the cabozantinib arm. Median PFS with respect to PD-L1, so PD-L1 negative patients achieved a median PFS of 4 months. PD-L1 positive had around 4.7 months, and patients with unknown PD-L1 achieved a median PFS of 5.4 months. So coming to overall survival, the combination of cabo plus atezo achieved a median overall survival of 13.8 months, and the cabozantinib alone arm achieved a median overall survival of around 9.4 months. So with respect to PD-L1, with patients with PD-L1 negativity showed achieved a median OS of 6.8 months, as compared to 10.4 months with PD-L1 positive patients, and PD-L1 positive patients and PD-L1 patients who had unknown status had achieved the median OS of 17.4 months. So this is the efficacy summary, and in a nutshell, it's a combination of previous slides, which summarizes that close to 80% disease control rates in the combination arm as compared to 65% in the cabozantinib alone. Median PFS of 4.5 months in the combination as compared to 3.4 in the cabozantinib arm. Median duration of response was somewhere around 5.8 months, so quite lower as compared to 10.6 months in the cabozantinib arm. And if you see the overall survival, this was 13.8 months, improving with the PD-L1 expression, and it was 9.4 months in the cabozantinib. So coming to the safety summary, so these were quite well in comparison, mainly leading to dose reductions, dose withheld, dose delays. These were to the tune of 40% with respect to cabozantinib in the combination arm, and it was 58% with the cabozantinib alone. Again, discontinuation rate due to treatment-related adverse events of 14% in the cabozantinib, 10% in the atezolizumab. Combination combination was 6%, and either alone was 16%. With respect to the alone arm, it was 10% in the cabozantinib. There were some crossovers, so 3% in the atezolizumab, either in 10% and both in again 3%. So this is the treatment-related adverse events in the combination arm and the cabozantinib arm, and this is well matching with the side effect profile which we have seen in the literature, and these are quite well balanced, comparable between both arms. So again, adverse events of special interest. This is immune-related, so these are slightly higher in the immunotherapy arm. Grade 3, grade 4 events were slightly higher as compared to the cabozantinib arm. Rest are mainly most comparable. So to conclude here, in the patients with advanced non-squamous non-small cell lung cancer, previously treated with ICI, cabozantinib plus atezolizumab demonstrated an encouraging clinical activity. Cabozantinib alone did demonstrate a modest clinical activity. Responses were observed with cabozantinib plus atezolizumab, irrespective of known PD-L1 expression. Toxicities of both the drugs and cabozantinib alone were consistent with those two previously reported in literature. And there are again two trials which are evaluating the same setting. One is a phase 2 trial of cabozantinib plus nivolumab versus standard chemotherapy. Another is a phase 3 trial of cabozantinib plus atezolizumab versus docetaxel in patients of non-small cell lung cancer who was previously treated with ICI and platinum-based chemotherapy. So that would be the first study. And so this is the second abstract. So this is an updated analysis of atezo-brain trial. And in this study, what they have tried to see is a setting where the patients are present with brain metastasis, because one of the limitation of previous studies of immunotherapy, immuno-oncology molecules is most of the patients with brain metastasis have been excluded. So an attempt was made to study these patients who have brain metastasis. So atezolizumab plus PEM plus carbo was studied in patients with advanced non-squamous non-small cell lung cancer with untreated brain metastasis. So again, the background I have already discussed. We know that patients with brain metastasis, if they are given whole brain RD, it delays the systemic treatment. So that may impact the outcome of these patients. So this study was designed on that basis. So this was the study design. We had stage 4 treatment naive non-squamous non-small cell lung cancer, untreated brain metastasis, EGFR ALK negative, and fit performance status with any PD-L1. They had measurable systemic and brain lesions with no neurological symptoms, or controlled with anticonvulsants on low dose dexamethasone with less than 4 mg or equal to 4 mg per daily dosing. No leptomeningeal carcinomatosis. So around 40 patients were included in the study. Tumor evaluation was done by body CT and brain MRI every 6 weekly till the 12 weeks, and thereafter it was done.
Slides are not moving.
Yeah, Samit, your slides are not moving, Samit. Actually, in fact, the atezo brain starting actually.
Is it moving now?
No.
Still, the older presentation is shared. You have to
correct.
stop this, cancel this, and open the new presentation.
Correct. Correct. Yeah.
Visible?
Yeah.
Fine. So, okay. So the second abstract is an atezo brain trial. So with this trial, with this abstract, they are trying to, the attempt is made to see the patients who have been treated with immune checkpoint inhibitors plus chemotherapy, but they have brain metastasis, because a flaw or a caveat with previous studies of immune checkpoint inhibitors was that the brain metastasis patients were excluded. So an attempt with atezo brain trial is done here to see these patients, how do these patients fare. So this is the background, and this is the study design. So we know that stage 4 non-small cell non-squamous cancer patients were included, EGFR ALK negative and any PD-L1 status. They had measurable systemic and brain lesions with no neurological symptoms or controlled with anticonvulsants and low-dose dexamethasone, and no leptomeningeal carcinomatosis. So 40 patients were included, and this was the assessment which was done with bodies, CT scan and brain MRI until the 12th week, and thereafter Q9 weekly until the progression. So a combination of atezo plus PEM carbo was given every 3 weekly for 4 to 6 cycles, and thereafter PEM atezo combination was used as a maintenance till an acceptable toxicity or a maximum of 2 years. The core primary endpoint was safety and investigator assessed PFS by RECIST 1.1 and then OPM, which is for brain lesions. And the secondary endpoint was overall response rates, overall survival, time to brain radiotherapy, quality of life, and neurocognitive function. So the database lock was December 2021 and minimum follow-up of 27 months was seen. So a Bayesian statistical design was actually used here, and I wouldn't go into detail of this, but a sample size of 40 patients was required under the assumption of PFS rates at 12 weeks of around 50% and a maximum grade 3 or 4 toxicity of 35% during the first 9 weeks. So this was the patient disposition. 43 patients were screened. 3 of them did not meet the inclusion criteria. Among the 40 patients who were included, 3 were able to complete 2 years of treatment. The end of treatment in the remaining were disease progression in 29 patients. 6 patients died. 1 patient, it was a PI decision to omit, and 1 patient had toxicity. So if you see the PFS rate at 12 weeks, it was close to 62.2%. Coming to the baseline characteristics of patient included in the trial, predominantly male population around 72%. With respect to smoking history, around 57% were current smokers, 27% were former smokers, and 15% had never smoked. Coming to the performance status, they were fit performance status patients, and with respect to brain metastasis, synchronous brain metastasis was seen in 92% of the patients, and metachronous around 7.5%. So total number of brain lesions with a median of around 5, ranging from 1 to 20. With respect to baseline corticosteroid use, close to 55% of the patients had used baseline corticosteroid and 45% had not used corticosteroids. With respect to PD-L1 expression, 50% or more PD-L expression was seen in 25%. 1 to 49 PD-L expression was seen in 25%. Negative PD-L1 was seen in 45%. So this was the updated safety analysis. Treatment was generally well tolerated and toxicity was consistent with the prior studies of atezo plus chemo. Median number of cycles which were taken with carboplatin were 4, pemetrexed around 8, and atezolizumab around 8. Treatment-related adverse events were grade 3 and 4 in 70% of the patients, and grade 5 adverse event was seen in 1 patient, which was febrile neutropenia infection. So coming to the neurological side effects, so if you see, these were the neurological side effects to the tune of 2 to 7-10%. Mostly seizures, headache, insomnia, anxiety, dizziness. These were seen. Hallucination, grade 4 was seen in 1 patient. Coming to the overall responses, so they had developed both systemic and intracranial responses. Systemic overall responses was 45%, and intracranial responses were comparable. This was to the tune of 42%. So focusing on systemic overall responses, so 43% patient had partial responses, 3% had complete responses. Stable disease was achieved in 40% of the patients, and progressive disease in 10%. With respect to the intracranial responses, partial responses were seen in 30% of the patients, stable disease in 42%, 12% achieved complete responses, and 13% of the patients had progressive disease. So this is again a waterfall plot showing the responses. So 6 patients which had progressed, 3 of these patients had progressive disease in the body and stable disease in brain, and 3 patients had progressive disease in the brain. So coming to the exploratory analysis of overall response rate with respect to PD-L1 expression. So what they found was, so this was the RECIST extracranial response. This is the brain response by the RANO-BM criteria. And there was no difference in systemic response rates between the PD-L1 positive and negative patient extracranially and as well as in the intracranial response. So the updated survival analysis suggested that the median PFS in the extracranial was around 8.9 months. In the intracranial, median PFS was around 6.9 months, and the median overall survival was 11.8 months, with 2-year overall survival rate of 27.5%. Coming to the other exploratory analysis of PD-L1 expression with respect to corticosteroid use at baseline. So median overall survival with respect to PD-L1 expression was somewhat better in patients who had higher expression. Overall survival of around 16 months, 16.6 months in PD-L1 positive patient versus 10.4 in PD-L1 negative patients. Again, patients who had corticosteroid did somewhat inferior. So median overall survival in patients who had no dexamethasone was 15.7 months versus 10.7 months in patients who received dexamethasone. So coming to the post hoc analysis of time until the patients were started on brain radiotherapy. So median time to brain radiation was 10.9 months, and thereafter whole brain radiation was given in 40% and stereotactic in 20% of the patients. With respect to median EFS, which was 7.62 months, and at the end of 18 months, 10.3% EFS was still there. So to conclude this trial, this was a Bayesian phase 2 trial which enrolled the targeted population, and in patients with non-squamous non-small cell lung cancer and untreated brain metastasis, chemo plus atezo had a favorable safety profile and yielded a 12-week overall PFS rate of 62% and median intracranial PFS of 6.9 months. Systemic intracranial overall response rates were similar, and most responses are concordant in brain and body. Despite being a population of poor prognosis in the final analysis, 27% of the patients were still alive at the end of 2 years. Initiating chemoimmunotherapy in patients with non-small cell lung cancer and untreated brain metastasis without clinical impairment could be a valid therapeutic strategy that allows to delay whole brain radiation therapy. So with this, I'll stop here, and I thank you all for your patient hearing.
Thank you, Dr. Samit, for that excellent presentation. Dr. C.N. Patil, sir, opinion, please.
Yeah, thank you, Dr. Samit Purohit. It was a very lucid presentation. And we have come a long way in the management of non-small cell lung cancer, and still a long way to go. And a lot of things have evolved. We progressed from histology doesn't matter to histology matters to again histology doesn't matter. And these two very interesting abstracts have looked up on progression after immune checkpoint inhibitors. These are very difficult subset to treat. And the only hope is that all these drugs become more and more affordable to us, and we start using in our clinical practice and see a meaningful overall survival in our patients. Thank you.
Dr. Patil, sir, as you rightly said, those two subsets actually were chosen because, as you rightly said, both the subsets were the very difficult subsets where we don't know what to do. At least affordability, at least okay, we have something to offer them. The question of affordability is next. At least yeah. There is some data to say that okay, we can say a patient, we have a data, something to show. At least the
scientific progress is definitely laudable, and we have options for our patients where the difficult to treat subset patients are surviving for more than a year and 2 is definitely remarkable.
Yes. So can you stop sharing your screen?
I thank Dr. Samit Purohit and Dr. C.N. Patil sir for their excellent valid input. We'll just, in the interest of time, we'll just quickly move on to the last session. We are coming to the last session, AstraZeneca sponsored session, small cell lung cancer. There are two sessions. One is Dr. Sai Vivek, and the second one is Dr. Anita Ramesh. First, I will welcome Dr. Sai Vivek, Senior Consultant Medical Oncologist at Shankara Hospital, Bangalore, for his presentation. Dr. Sai Vivek, over to you.
Yeah, hi. Good evening, sir. And yeah, in the interest of time, I will start immediately. The small correction, it is actually non-small cell lung cancer stage 3 is what we'll be talking about today. And hopefully my slides are visible and I'm quite well audible. Hello.
Yes, sir.
You are very much audible, and slides are seen.
So I think after a feast of knowledge sharing in terms of lung cancer, I'm going to pull you back into stage 3 for just a bit. So stage 3 lung cancer, as we know, is almost as bad as stage 4 in the management. Almost 80% of the patients from 3B to 3C eventually tend to relapse, and their 5-year overall survival drops down to 25% for stage 3B and dismal 12% for stage 3C. So in this context, there was a requirement to get a new drug which post concurrent chemoradiation would increase the overall survival of most patients. So we're going to discuss that with the help of a case. So a 59-year-old gentleman presented in July 2020 with cough, weight loss for the past 3 months with no history of any comorbidities. And the X-ray here is definitely showing a mass in the right lung upper lobe, and also lymphadenopathy, which was right paratracheal and right hilar region. So the necessary biopsy and staging investigations were done. So histopathology, it was moderately differentiated adenocarcinoma. MRI was normal. PD-L1 was done routinely, which was negative. One thing to note here, EGFR was positive. So as per the latest AGCC staging, he falls into stage 3B because size was more than 5 centimeters, and the mediastinal, ipsilateral mediastinal lymph nodes were positive. So a 3B adenocarcinoma, which was EGFR positive. So the standard of care treatment options at this moment, as per all the guidelines, is concurrent chemoradiation. And we all know that along with radiation, there are various regimens which can be used. And the most commonly used for non-squamous can be PEMSIS, or Paclitaxel also can be used weekly for both stage 3A and 3B. And all of them, as per these phase 2, phase 3 trials, have shown a median overall survival of around 2 years with the concurrent regimens. And the old age etoposide and cisplatin is always there. And though concurrent is what we aim to practice because of the poor performance status and elderly age, most of us in some patients tend to go for the sequential regimens. So in the sequential regimens also, Paclitaxel, Avibactam, and cisplatin has been shown to have some effect. But when we come to the debate of whether sequential or concurrent is better, multiple trials and meta-analysis has proven without any doubt that wherever possible, concurrent is superior to sequential in terms of overall survival and even locoregional relapse. So this patient was given concurrent chemoradiation with Paclitaxel, and which he completed in September 2020. And as we see in the post concurrent chemoradiation scan, there was a definite response from the tumor. So the tumor had definitely shrunk post concurrent chemoradiation. So this is again what there were a lot of trials which evaluated the benefit of consolidating post concurrent chemoradiation, either with chemotherapy or with some EGFR inhibitors in the trials listed here, but none of them were able to demonstrate a significant clinical benefit, as we see the p-value here, that giving anything post-concurrent chemoradiation really did not improve the overall survival. So hence the unmet need was established. So then came the Pacific study, which was a phase 3 randomized double-blind placebo-controlled multi-center international study where patients were randomized into a 2:1 fashion after concurrent chemoradiation, and they had to receive at least 2 cycles of chemotherapy along with radiation. So the durvalumab was dosed at 10 milligrams per kg for up to 12 months duration versus placebo. So a good number of patients were randomized. It was 476 in the durvalumab arm and 237 in the placebo arm. The primary endpoints were PFS and overall survival, with overall response rate, duration of response, safety, and patient-related outcomes as the key secondary endpoints. So one thing to note here, so in our patient, I had mentioned that he was EGFR mutation positive. We might think there is adjuvant osimertinib, but one thing to just remember, the adjuvant osimertinib trial, the stage 3A was the last stage in stage 3, which was included. 3B and 3C were not included. So we do not have data for adjuvant osimertinib in 3B and 3C. So 4, again, we know it has been well established. But in this specific trial, though there were very limited number of patients with EGFR positive status, they were around 6% or 30 patients were there. The numbers are too small to make any reasonable conclusions out of it, but that one thing has to be noted. So in the latest updated analysis, at 5 years, 42.9% was the overall survival in the durvalumab arm versus 33.4 in the placebo arm. So this definitely showed that addition of 12 months of durvalumab after concurrent chemoradiation has a meaningful clinical benefit, almost up to 10% improvement in the overall survival at 5 years. So even the PFS was very impressive at 33% versus 19% with durvalumab. So after this, this was the trial setting. So what about the real world setting? There was a French analysis where 599 patients were enrolled in the French cohort, temporary authorization for use, the CATU, where they were given adjuvant durvalumab post-concurrent chemoradiation for consolidation. So one thing which was different and noteworthy in the French trial was, the French cohort, in the Pacific trial, 1 to 42 days was the duration given for the patients to be enrolled. And we are talking about patients here who are elderly, history of smoking, and they would have been just given radiation. So there's a high chance of interstitial lung disease. But in the French trial, even 40% of the patients were randomized after the duration of 42 days. So that is close to 1.5 months later also, 40% of the patients were enrolled. And the data was very similar to the Pacific trial. So the responses and the survival rates were very similar to what we had just seen in the Pacific trial. So this real world experience reestablishes the fact that durvalumab in stage 3 lung cancer post CTRT definitely improves the overall survival. The patient was started on durvalumab post his concurrent chemoradiation, and there was a good response seen with durvalumab, and he continued to take the therapy. But after around 15 doses of durvalumab, he came with complaints of cough and breathlessness, and PET-CT definitely showed a recurrence. Now, the next steps in the management, yes, we all would go back to systemic chemotherapy is what the patient did. So in the Pacific trial, what they noticed was the intrathoracic progression was the most common in the durvalumab arm, and those patients could be again rechallenged with radiation, some of them needed to go for the needed to go for systemic therapy, or if that progressed systemically, they could have been challenged with EGFR or EGFR TKIs. So durvalumab has more prevalence of intrathoracic progression compared to the placebo group. And the duration of response obviously was much better in the durvalumab arm. And most of the patients in the Pacific trial post-progression on durvalumab went on to take systemic therapy with the platinum doublet, compared to a few patients who went on to take immunotherapy post-progression in the placebo arm. So this is the most important thing. All of us have heard that durvalumab does increase the chances of interstitial lung disease. So the grade 3 interstitial pneumonitis or interstitial lung disease or post-radiation was only seen in 3% or 3.5% in the durvalumab arm, and 3% was also seen in the placebo arm. So one thing to note, we need to check the baseline lung status of every patient before enrollment, and serial monitoring of patients with already damaged lungs and COPD due to prior smoking. And even after 42 days, it's never too late to counsel the patient and give them the option of durvalumab and increase their survival rates. So the key takeaways are multidisciplinary team approach gives the best outcomes for patients in stage 3 NSCLC. Concurrent is definitely better than sequential, and consolidation with chemotherapy as of now does not improve outcomes. And the first and only approved immunotherapy to demonstrate a 5-year overall survival and PFS benefit is durvalumab, and it should be offered as a treatment option to all our patients post concurrent chemoradiation. But conventional thinking, if there is an EGFR mutation present, patients do not respond well to immunotherapy, but we need to await for more mature data whether we can use it in 3B and 3C setting, that is adjuvant TKIs. They were used before. Erlotinib and Geftinib were used. They did show a good DFS benefit, but not a overall survival benefit in the previous trials. And even the osimertinib in the adjuvant setting, overall survival data is still awaited. Hence, at this moment, durvalumab is the treatment of choice for stage 3 post-concurrent chemoradiation, irrespective of the PD-L1 or the driver mutation status. Thank you.
Thank you, Sai Vivek, for that excellent presentation. In the interest of time, I quickly move to the next session. I welcome Dr. Anita Ramesh, Senior Consultant Medical Oncologist, Savita Medical College. I welcome you, ma'am. I welcome the panelists, Dr. Kiran, JSS Medical College, Mysore, Dr. Rakshit, Surgical Oncologist at HCG, Mysore, Dr. Naveen Anvekar, Consultant Medical Oncologist at Narayana, Mysore, and Dr. Vishwajit Kepai, Medical Oncologist, Mysore, Dr. Arvind, Radiation Oncologist, Associate Professor, CMC, Vellore. I welcome you all, friends. Ma'am, over to you.
Yes, thank you very much. Okay, nice to be a part of this meeting. One amazing thing which I observed is that lot of logins, just now 40, but all throughout it was almost 50 plus. So that's a big achievement. Thanks to the organizers for having me here. And yes, it's quite late night on a Saturday, but still we will proceed on the discussion of the optimal management of extensive stage small cell lung cancer. Yes, coming to the, as we heard our speaker talking about the use of durvalumab in the third stage non-small cell lung cancer. Yes, it has revolutionized the treatment as on today, and thus we have one of the important drugs which are available with us. So I wish all my panelists are here. Dr. Kiran is there? Dr. Kiran, please.
Yes, ma'am.
Yeah, thank you. Dr. Naveen?
Yeah, I'm there, ma'am.
Yeah, Dr. Rakshit?
Yes, ma'am, I'm here.
Yes, Dr. Arvind. Yeah, we have, Arvind is there?
Yes, ma'am. Yes, ma'am.
Yes, okay. So let's move on to the first case, a 62, a good smoker. There is shortness of breath, hemoptysis, weight loss, early satiety, has a liver enlargement on physical examination, enzymes are elevated, CT shows a left lower lobe nodule. Okay, coming to the surgeons first, Dr. Rakshit, how will you proceed?
Ma'am, we usually go for an FNAC followed by invasive mediastinal staging or PET scan usually to rule out the mediastinal disease.
Okay, Dr. Rakshit, as on today, would you still want to do an FNAC, or with the expertise with the intervention radiologist, true cut biopsy would be the first option?
Yeah, nowadays true cut biopsy is preferable.
Both true cut biopsy. Okay, another quickly, do you want to do the PET CT before you do the biopsy?
Yeah, usually we'll go for full workup, ma'am. For biopsy, PET, everything will together, we'll finish it off.
Yeah, do the scan and then do the biopsy of the PET positive area. Okay, being a surgeon, I just quickly wanted to know what are the different options of biopsy from a surgeon as well as a radiologist perspective and a pulmonologist perspective, and how do we get the tissue, whichever side the lung SOL is?
So preferably, if possible, US guided biopsy or EBUS. If not possible, then CT guided biopsy. If that is not possible, then thoracoscopic guided biopsies can be preferable.
It's a VATS.
Yeah, it's VATS.
Okay. Otherwise, you have the endoscopic biopsy.
Yeah, endoscopic biopsy. Yes.
EBUS is there. Okay. Now, again, another question to you: if there is effusion, how do you proceed with diagnosis?
So that is a difficult case scenario. Then we have to drain the pleural fluid, and then we can go for a scan and then look for the viable area for biopsies.
If you don't get, many of the times you will get a cytology negative also, doctor.
Yeah, then we'll go for PET scan.
PET scan and PET scan biopsy. Therefore, nothing is there in the PET recurrent effusion.
So then, I don't know, we have to refer to medical oncologist.
No. You already told earlier, VATS, thoracoscopic biopsy.
Yeah, that is VATS biopsies will try. If no area is feasible, then we don't know what.
Yes, correct. You already said. Okay. Now, again, the patient is still with you. You have not referred to the medical oncologist. Okay. You have sent for the biopsy. What you have done a PET CT. Now, question is that suppose if you have not done a PET CT, would you do an MRI brain? Or if you have done a PET, means you have done everything. So how will you go about? If MRI brain needed?
In current scenario, PET can pick up the majority of the brain mets. If it is not available, then I'll go for an MRI.
MRI. Now, MRI, rightly you said, doctor, MRI is included in the armamentarium of the treatment diagnosis of even small cell lung cancer and definitely small cell lung cancer. Okay, another quickly to you, is that any role of surgery in these cases? Which stage will operate? Small cell lung cancer. No, not extensive. Small cell lung
Yeah,
cancer.
in limited stage, if it is T1, T2, N0, M0, then there is a definite role of surgery followed by adjuvant chemo. And extensive is absolutely no role.
No role. You would
Until unless there is a misdiagnosed as a mixed histology where NCLC is there, other atypical carcinoid has been misdiagnosed, then we then maybe go for surgery. Then it may be diagnosed as SCLC later. Then patient will go for further treatment.
Yeah.
Otherwise, extensive stage no role.
No role. Yes. Now these are as per the NCCN guidelines. Yes, we need to do a general markers and then MRI brain has to be done. If not, CT needs to be done. PET has been PET has no role in limited stage. But if you have a suspect, yes, a PET scan informs. And smoking cessation, remember, is within the guidelines now. Counseling has to be done so that they don't continue, and also to the family members. Molecular profiling. Okay, now coming, Dr. Vishwajit Pai is also there. I forgot to call his name. Dr. Vishwajit is there?
Yes, ma'am.
Yeah. Okay, Dr. Vishwajit, then we start. I just missed your name there. Okay, what are it says over here, the last point, molecular profiling for never smoker with extensive stage. What will you ask for?
NGS panel, ma'am.
Everywhere NGS you want to do?
No, in a definitely the rule in our practices, if a non-smoker has developed SCLC, then definitely we have to rule out definitely a familial or a hereditary cause, which we will not be able to pick up in a regular hotspot analysis. So NGS is the way in this situation. Whereas in other situation like NSCLC, yes, I definitely go with the panel of tests, but in this situation, definitely NGS.
You would run the NGS
Yes,
and
yes.
whatever it is. Okay, so this is the patient's profile, and then as we discussed earlier that had the upper abdominal pain, liver was enlarged, and that's the liver showing the PET CT, and brain MRI did not have any abnormality. Liver mass showed metastatic involvement. Biopsy was done, and there was a mass in the left lung. So it becomes an extensive stage small cell lung cancer. Now coming to we stick to you, Vishwajit. Histopathology, like what would you now? Okay. Okay, now you said that you would like to do NGS. NGS, what are you going to look for? Your report has come small cell lung cancer. Pathologist has done the IHC and given you a report. So what are you what do you want to do what are you going to look for in that molecular studies?
Many times when we do NGS panel for we do find mutations which are not targetable. Many times it is something like a TP53 mutation or where we can't find any targetable. I recently had a patient of SCLC for whom I did the NGS panel, and it did show a TP53 mutation. So though the rule is we might be lucky at times to find some targetable mutation, but definitely the targeted mutation will not be used as treatment in the first line. The combination treatment of carboplatin with or cisplatin with etoposide will remain the first standard of care. As long as treatment is concerned, I don't think it will have any bearing in the first line.
Yeah, that's what I wanted to know. Our molecular testing in a small cell lung cancer, when you have the report in the first line, we don't wait for it actually, unlike the non-small cell lung cancer. So may not be having any of the bearings for the treatment. Okay, let's come to Dr. Kiran. Chemotherapy regimes in first line, but this particular patient. Number of cycles, platinum, which platinum, okay, and the role of irinotecan or other chemotherapies. All the questions are for you.
We'll go with cisplatin and carboplatin plus etoposide regimen.
Day 1, day 2, day 3.
Yeah.
And that's the standard of care. How many cycles will you give?
We'll give four to 6 cycles.
And do a PET scan and see.
Yeah.
And you want to give any other treatment? Any other drugs as preferable? Irinotecan based?
No, ma'am, that will keep it as a second line.
Might not be used.
Yeah.
First. Okay, but then we also need to see the platinum eligibility. Okay, and if they are eligible for cisplatin, non-eligible carboplatin.
Yeah.
Etoposide has to be, and also be very careful. You saw the picture of the liver. Okay, so it's completely studied with metastatic disease. So we need to know the liver function and how much is the liver compromised, and is hopefully everything should be okay. Then you can proceed with the regime that you said. Okay, next coming to Dr. Navin.
Yes,
okay, what would be your first line of therapy with this liver mets, like platinum etoposide or platinum etoposide immunotherapy? Which one would you like to go for?
If the patient can afford, I will definitely consider the patient for platinum etoposide with immunotherapy combination, madam. If there are any autoimmune disease or contraindication for immunotherapy, I will definitely go for 4 cycles of chemotherapy followed by maintenance immunotherapy.
Okay, not upfront immunotherapy.
Upfront with maintenance.
Okay, after that you stop the chemo drugs and you continue the immunotherapy. Why do you say this?
So based on this one data on durvalumab and this one atezolizumab, which are approved for this one extensive small cell lung cancer.
Okay, so so that's the different way of the same question. Why would you use the immunotherapy along with it? Okay, before we come to this, I want to speak to Dr. Arvind. Okay, now you saw the liver. Okay, any liver directed local therapy for SPRT? And next question is, where is the role of a radiation oncologist as far as small cell lung cancer is concerned? And then we will come to extensive stage.
Yes, sir. The liver, actually, the metastases look very extensive. So in oligometastatic disease with the primary and other disease under control. So if there are only less than 3 to 4 sites of mets, maybe we'll consider SBRT, depending on how the response to chemotherapy is. Otherwise, there is very limited role. Apart from this, there is some role of RT for the brain. Suppose the MRI brain is showing some metastasis, then we might consider whole brain radiation, or if extensive stage with very good response to chemo, we can consider prophylactic cranial radiation.
Prophylactic cranial radiation, therapeutic radiation, also radiation to the primary site?
Yes, definitely primary site also. There is some randomized evidence from the Dutch trial. We showed that although at the expense of esophagitis, grade 3 esophagitis, there is some role of primary lung irradiation also for a lesser dose, probably around 30 grade 10 fractions.
Okay, to be given to the primary site.
Yes,
okay,
yes.
Yeah, just coming to these randomized data shows that superiority of the drugs when you use the platinum and etoposide in the first line setting of these extensive stage. Durvalumab is the Caspian study, giving you a median overall survival of almost a year, and approved in first line along with combination. Rightly now the panel is told. Atezolizumab, but that's the IMpower 133. Again, similar median overall survival, also approved in the first line. Pembrolizumab and nivolumab with ipilimumab, yes, to be approved. And if you see the study design with EP, then the median overall survival, almost it is comparable, okay? And the superiority of the etoposide platinum in first line does remain. Now, coming to the most effective first line therapy is very, very important to the patient's outcome, and because you might not get a chance for the second line as well. So the patient's eligible to receive treatment in subsequent line. You see, if you're going to treat 80 to 100 cases, yes, it comes down to 30%, 50% and less than 20. Coming to Dr. Vishwajit, what is the trend in your practice? Do you really get patients, and what do you do in second line, and how many of them are willing for treatment at that point of time?
Second line, I would say a majority of the patients when present with recurrence do have brain metastasis. So post whole brain radiation, it depends how the patient responds to the whole brain radiation. So, and the performance status at that point of time. A lot of patients will not be able to will not be fit for any further chemotherapy. In such situation, we'll end up suggesting only supportive care and referral to a palliative care center. But in patients who continue to be, in a good general condition post recurrence, I am using this combination of irinotecan and paclitaxel, which has given me excellent results. Though it is not the combination as such is not suggested, but these are active agents which has helped in my practice. I recently have a patient who's completed 1.5 years since recurrence on of a patient of SCLC. So my second line choice is chemotherapy with a irinotecan or a
That's second line chemotherapy.
taxane-based combination.
Correct. So the concept that what we are trying to drive in at this point of time, if the patient is deserving, it is better to expose them the immunotherapy. But definitely, if logistics are in place, if the other financial issues are not there, this will also improve outcomes and can be used upfront. Okay, now in this context, I just wanted to talk to Dr. Rakshit to say, is there any role in whenever the patient has relapsed, as you see the second line, and we are planning for second line therapy, like how what Dr. Vishwajit said, if there's an oligometastasis, is there any role of surgery as far as small cell lung cancer is concerned? Do you really?
Actually, there are no data suggesting there is any survival advantage from surgery for residual diseases. See, recently, I have seen one patient. There is an isolated lung lesion, was residual disease was there. So we did a surgery, but it is came out to be a converted histology of NCLC. Combined histology was there. So otherwise, actually there is no survival benefit from surgery.
Yeah, the conversion is there, and then okay. Yes, the role of, unlike the other tumors, the small cell lung cancer, even with an oligometastasis, the surgery does not benefit any much of them. Now, if you see the systemic therapy, okay, yeah, preferred regimen is the platinum and etoposide at the given dose, and as mentioned in the recommended dose. So that's how the schema, and that is the standard of care in all. Now, if you see the box in red, which tells you that atezolizumab 1200 milligram day 1 can be given, and the whole thing can be repeated 21 days, 4 cycles, and continue maintenance, okay, till progression. And durvalumab is 1500 milligram every 21 days, again 4 cycles. So these are the 2 approvals which has there for us to use the durvalumab, and the drug durvalumab is we are more familiar with, and I'll come next to Dr. Kiran. Okay, if you see the NCCN guidelines over here, durvalumab is there, atezolizumab there. What is your preferred drug?
I'm more comfortable with durvalumab, ma'am.
Why?
Because I've used it.
Why atezolizumab you must have used for other tumors? That's also a good drug.
Yeah. I think there's not much of a difference between the two.
So why do you prefer one or the other? The Caspian data and the Empower 133.
Yeah, 133 data.
I think we have to consider which platinum we have to use. I think atezolizumab is recommended only with the carboplatin.
Carboplatin, yeah.
We can't use cisplatin. And also with respect to brain metastasis, one of the trial completely excluded patients with brain metastasis. So
the atezolizumab trial.
Yes, ma'am.
Yeah, so durvalumab has more data with brain penetration, and you can go with any of the platinums of your choice as per the study says. Okay.
So, ma'am, sorry to interrupt the presentations. We have definitely another 2 minutes to run.
Yeah, we'll finish. We'll finish. Okay. What are the criteria that can be considered while choosing the immunotherapy? Yes, Dr. Navin.
Yeah, madam. This one, absence of any what you called this one autoimmune disorders, and also the presence of brain mets, as said by Dr. Vishwajit. This one durvalumab group included patients with brain mets, and also this one durvalumab group used both cisplatin or carboplatin, and also durvalumab they used 4 or 6 cycles of chemotherapy. Versus only 4 cycles of chemotherapy in case of atezolizumab, and maintenance of durvalumab was more easy because they used once in 4 weeks regimen rather than once in 3 weeks regimen.
Yes, these are all the points rightly said. All outcomes, no biomarker selection was there in the Caspian study. Untreated brain mets, radiation, the control arm was allowed, it was included, and up to 6 cycles of chemotherapy and carboplatin was allowed. So it allowed treatment with cisplatin, carboplatin, and asymptomatic, untreated or treated brain mets were all included. So that's the major difference in the yellow box, okay, and which was the durvalumab arm. And if you said the Imfinzi with EP, the first and the only approved IO to demonstrate a very statistical and significant improvement in overall survival. And you see the curve separating 17.6 and 5.8 at 36 months. And more than 3 times the patients are alive at the 3 years, and the clear separation is also sustained, and there's a flattening after that, which is observed even beyond that, and which supports a sustained long-term overall survival benefit. I think with the paucity of time, I think the organizers wants us to stop, and I thank everybody. And I think this is a very important slide to conclude with. Thanks to Dr. Kiran, Navin, Raksit, and Arvind and Vishwajit. Also thank Dr. Srinivasan from HCG Mysore for bringing us all together. Thank you very much.
Thank you, ma'am. Thank you so much for that wonderful moderation. I thank all the panelists for their excellent participation. Thanks for coming to such a wonderful panel session. So with this, we'll come to the end of day 2 lung cancer symposium. I thank all the speakers, delegates, attendees for this conference. Without you, this wouldn't be successful. And I would like to thank the Horizon and team for their excellent work conducting the day 1, day 2 session. It just went like that. We didn't realize how flawless it went. It was such a excellent teamwork from the Horizon event management. Thanks to Mr. Tarun, Pooja, Egfr ji, and their team. Thanks for that help. And I thank my coordinator Charushila, who was phenomenal in preparing all these slides and sending to the speakers. I thank each and everyone and make this meeting very successful. Thanks again, one and all. Good night. And last but not the least, I want to thank the pharma sponsorship. Without them, this wouldn't be complete. I thank Pfizer, Lilly, AstraZeneca, Roche, Novartis, BMS, Natco, Zydus, Co-Diagnostics, Glenmark, and Reddy's and Merck for their generous contribution for this wonderful scientific symposium. Thanks one and all, and good night. Have a pleasant weekend. Thank you so much for active participation.
Thank you, Dr. Srinivasan.
Thank you, Srinivas.
Thank you so very much on behalf of both my colleagues, Pooja and Egfr. It's a wonderful, a part of this conference. So stay blessed, stay safe. Good night from all of us.
We look forward for more scientific meetings in future with the same kind of support, from audience, speakers, all so supportive. Thanks for all the help. Thank you so much.
Good night. Good night, sir. Good night.